Hello and very good morning to all esteemed doctors and guests. A very warm good morning to you all. On behalf of Eternal Hospital and Solaris, our Sun Pharma division, I welcome you all to the second and last day of Medicine Update 24 Season 1. Today we will continue to explore latest advancements and breakthroughs in various medicine specialities. I request you all to be as attentive as you all are tomorrow. Once again, welcome you all. So today's first session, I would like to invite Dr. Saket Agrawal on the podium, please. And his topic will be upper gastrointestinal bleed, how to approach. The panelists for the session will be Dr. Dinesh Chauhan, Dr. Narendra Solanki, Dr. S.D. Kolani sir, Dr. Pramod Saxena sir, Dr. Praveen Gupta sir, and Dr. Suresh Mehta sir. Please come on the dais and take your chairs, please. Dr. Suresh Mehta sir, please. Sir, please. Pramod sir, please. Akhilesh.
Yeah.
Good morning. Upper GI bleeding, how to approach. Dr. Saket Agrawal, Consultant Gastroenterologist, Gynaecology Hospital. Over to Dr. Saket.
Good morning, seniors and my dear colleagues. At the outset, I would like to thank the organizing committee for giving me this opportunity to present the topic upper GI bleed, how to approach. Myself, Dr. Saket Agrawal, I am working as a consultant gastroenterologist and hepatologist at Gynaecology Hospital, Jagatpura. So now we proceed to the topic. First, we'll discuss what are the causes of upper GI bleed, what you label it as upper GI bleed, and then how to manage it. So what is upper GI bleed? Any bleed which occurs proximal to the ligament of threads is labeled as upper GI bleed. That means esophageal, gastric and duodenal bleed, we label it as upper GI bleed. So the patient can come as hematemesis, that is blood in the vomiting, or they can come to you with melena, that is black tarry stool. So any patient who comes to you with hematemesis or melena, you should always suspect that this upper GI bleed and you should start your management of the patient. Now what are the common causes of upper GI bleed? So we can divide the causes into three ways. That is, one is the causes related to the esophagus, causes related to the stomach, and causes related to the duodenum. So we'll take one of them. We first start with the esophagus. The common causes which can cause bleed in the esophagus are esophagitis, that constitutes around 10% of the cases. Second is the variceal bleed, that is underlying portal hypertension, which again constitutes around 8 to 9%. Third is Mallory Weiss tear. When a patient do vomiting or retching forcefully, then there is some mucosal break in the wall, and that leads to the upper GI bleed that we label as Mallory Weiss tear. And the fourth is uncommon causes like malignancies of the esophagus. So you have esophagitis, you have portal hypertension leading to varices formation, you have malignancies, and you have Mallory Weiss tear. These constitute the important causes of the esophagus related upper GI bleed. Coming to the gastric causes, you have peptic ulcer disease, you have gastritis, you have vascular malformations, that is Dulafy's lesions or telangiectasias, and you have the malignancies. So out of them, ulcer and gastritis constitutes a major cause for the gastric GI bleed. Coming to duodenum, you have peptic ulcer disease in the duodenum, you have vascular malformations, sometimes you have bleed from the biliary system, that is hemophilia, you have bleed from the pancreas, that is hemosuccus pancreaticus, you have aortoenteric fistulas. So these are the causes for duodenal upper GI bleed. So once we know the causes of GI bleed, upper GI bleed, then we proceed to how to approach a patient who comes to you in the emergency. First, main part is the history. You assess that patient has got a upper GI bleed, or he has got a epistaxis, or it's oral bleed, or it's hemoptysis. When you are sure that it is upper GI bleed, then you proceed to see historically whether the patient has got a signs of dehydration or not. If he says he is feeling thirsty, he is feeling giddiness, chakkar, that means there is a significant amount of upper GI bleed. You assess for the anemia in the same way, you assess that how much he has bled, so that you can be on your top priority for the blood transfusion. You assess the underlying comorbid diseases like coronary artery disease, liver disease, and kidney disease. You take the history of the drugs. Patient may be taking analgesics, patient may be taking antiplatelets, patient may be on the anticoagulants. So you ask the history. If you don't ask, then the patient may forget to tell you. Then you ask the history of weight loss also, because now in elderly patients, the chances of bleed secondary to malignancy is also increasing. So you ask the patient whether he has lost weight in the past. So if he is losing weight, then you should suspect that he may be harboring a malignancy in the upper GI system, which may be the cause of upper GI bleed. Now once you are done with your history part, you examine the patient, and the foremost is the vitals. Second is the signs of dehydration. Third is the status of anemia. And fourth is signs of the other underlying diseases like CAD, CLD, or CKD. Now how to approach? We will start with this slide. How to approach when a patient of upper GI bleed comes to you in the emergency. The number one part is restoration of the airways. Because if you don't restore the airways, patient may aspirate and new patient may die. So the most important part is to restore the airways. If you think that patient has massively bled, patient is getting dull and drowsy, you secure the airways, you intubate the patient, that will save the patient. The second part is restore the circulation. If you are able to maintain the blood pressure until the definite treatment is carried out, you will be able to save the patient. So the classical teaching is get 2 large bore IV cannulas placed, whatever center it may be. It may be a primary center, it may be a district level center, but always restore the airways and get the IV access. If you have done these two things, then the half the battle is won. Then you take the urgent sample for the hemoglobin and the blood grouping, so that the urgent blood transfusions can be done. You start the IV fluids, normal saline or ringer lactate, so that the BP can be maintained. Now, the role of blood transfusion. You get the hemoglobin levels. If they are less than 8, you need to transfuse the blood. Try to maintain the hemoglobin above 8 grams, so that the time can be bide and the definite treatment can be done. And waiting for that, the patient will not succumb if you are able to maintain the airways and the hemoglobin levels. So the teaching is like, if you have a hemoglobin of less than 8 gram, you transfuse the patient with blood. If the patient's platelet is less than 50,000, you transfuse the patient with platelets. If the INR is more than 1.5, you transfuse FFPs and give vitamin K. So this is the approximate markings at which you start the blood transfusions. There can be variation depending on the patient's clinical status, but these are the classic teaching. Now comes the role of Ryle's tube. There is slight controversy whether we should put the Ryle's tube or not, but usually gastroenterologists prefer to put the Ryle's tube. The advantages of putting the Ryle's tube are, number one is, like if you put the Ryle's tube, you are able to assess the degree of bleed. So to assess the degree of bleed, you put the Ryle's tube, start the lavage with the normal saline. There's profuse bleed, you can call the endoscopist at night also if it is bleeding heavily. Second is, by decreasing the acid volume, the chances of clot dissolution decreases. So Ryle's tube again has an advantage. You can remove the excess acid in the stomach, the clot formation will fasten up, and the dissolution of clot will decrease. Third is, if you do the Ryle's tube lavage, doing an endoscopy will become easy, and doing the therapeutic intervention will be easy, because the stomach will be clean and you will be able to carry out the endoscopic intervention easily. So we put the Ryle's tube, we lavage the patient. When we do lavage, we should do it with the cold saline rather than water. So it's best to use normal saline while doing the lavage instead of the water. Now comes the medical treatment. What medicines you use? There are two important medicines which are used in upper GI bleed. One is the proton pump inhibitors and the second is the somatostatin analogs. Rest of the medicines does not have much role. So regarding proton pump inhibitors, you should use IV PPIs. You should start initial bolus dose of 80 mg followed by infusion of PPIs at a rate of 8 mg per hour. What is the advantage of giving the PPIs at this level? The PPIs will help to decrease the acid formation, and that acid decrease in the acid production will lead to rapid clot formation and decrease the rate of clot dissolution. So use PPIs at the start, use IV access, give a bolus dose followed by infusion. If you don't have infusion pumps at the periphery, you can give it in the fluid and start the IV fluid. Then second medical treatment is somatostatin analogs. What they do? Basically, they are splanchnic vasoconstrictors. They will decrease the blood supply to the upper GI tract. So they decrease the hepatic pressures, they decrease the blood supply, and by this action, they are beneficial mainly in variceal bleed. So if you have a patient suspected of underlying portal hypertension, you start somatoanalogs. That will decrease the splanchnic circulation and that will help in decreasing the upper GI bleed. You have multiple somatostatin analogs available with you, but mostly nowadays we prefer terlipressin over the other somatostatins. And the advantage of terlipressin is you can give it in a bolus form. You don't need infusion pumps. You can just infuse terlipressin 0.5 to 2 mg IV 6 to 8 hours. Just giving bolus doses will help you to control the bleed in variceal bleeds. There are studies which have used the somatostatin analogs in non-variceal bleed, and there have been some advantage of using them because they decrease the splanchnic vasocirculation, and that way they will decrease the degree of upper GI bleed in non-variceal bleed also. But the trials are going on, but till now we don't prefer giving these in non-variceal bleed. Now, once you have done with your emergency treatment, medical treatment, there comes the role of the endoscopist. So, doing an urgent endoscopy will always help in the clinical outcome of the patient. So, you have done the arterial lavage, you have accessed the IV lines, you have secured the airways. Now comes the role of endoscopist. Do an early endoscopy, see the lesion, what type of lesion it is, and then do a therapeutic intervention. So this is basically the different types of peptic ulcers. This is a forest class depiction. We can see this is 1A where you have ulcer with blood oozing out rapidly. This is a 1B where just blood is oozing but there is no stream of blood flowing. So these 1A and 1B are the dangerous peptic ulcers where you need to intervene fastly. This is 2A, 2B and 2C. This is a visible vessel on the ulcer. This is 2A. You have an adherent clot. This is 2B. And you have a pigment base. This is 2C. This is a 3 where you have a clean white based ulcer. This is the safest. So in these upper 1A, 1B and 2A, you have to intervene. If you will not intervene, then the patient will die. So either endoscopic intervention or intervention radiologist or surgeon needs to act in these cases very fast. Otherwise, you will lose the patient. 2B is a borderline case where the patient may get cured without endoscopic treatment, or you can remove the clot and do the therapeutic modality. Most of the patients of 2C and 3 will not need any endoscopic treatment and they will recover with the medical treatment only. So now, what are the various modalities which a gastroenterologist uses day and out? So we have coagulation treatments, we have sclerotherapies, we have clips. So this is all about the non-variceal bleed. So this is basically the telangiectasia, vascular anomaly, you can see vascular malformation. This is the organ plasma coagulation catheter. We have organ APC catheters available with us. We insert that electrode through the endoscope. We reach to that part of bleed. We focus that area. We clean that area with the water jet. Then we have two modalities of coagulation. One is the contact coagulation, other is a non-contact coagulation. APC is a non-contact coagulation. Here you keep the electrode slightly away from the mucosal surface, that is 5 to 10 mm away from the mucosal surface, and then you fire with your foot switch. The APC organ plasma coagulation clots the tissue, seals the vessel, and stops the bleeding. It's a very good modality, easily doable, not much care to be taken. You just fire the APC at the side and the bleeding stops. Second is the contact coagulation, where we use the bipolar cautery electrodes, where we touch that area with the electrode and then again we fire, and that clots the proteins and stops the bleeding. So, and then third is the injection sclerotherapy, where we have an injector, we insert it through the endoscope, reach to that lesion, we put out the needle and then inject sclerosants at the base of the ulcers, and that will control the bleeding. So these are the treatment modalities available for the non-variceal bleed. This is the clipping. It again looks quite easy to do. There is a mucosal bridge. You just apply the clips, seal the margins. You can apply 1, 2, 3 clips and you can control the bleed. So these are the good modalities, but they all depends that the area has to be clean. Good artery lavage has to be done so that the endoscopist becomes easier for him to do or seal these ulcer areas. Now we move on to the variceal bleed. So this is the endoscopic variceal ligation. We term it as EVL, done for the esophageal varices. So these are the esophageal varices. You can see these are the venous channels in the esophagus. So this is the endoscope. We put the hood over the endoscope. There are bands present over these hoods. We go into the esophagus, we suck the varix into the esophagus and we release the band. So this is the animated picture. You can see the varix getting banded. Now this is the endoscopic picture. You can see this is the varix, the band has already been applied. So this is a very good modality for the esophageal varices. Within minutes the bleeding stops and the patient is saved. Moving on to the treatment for fundal varix. In the fundus of the stomach, you have varices. In those varices, if you apply the band, they will slip out. So usually we do glue injection in these fundal varices. This is the fundal varix, large fundal varix. We put the injector inside, we keep out the needle and then pierce the varix. And then we inject the glue. Glue is just like Fevikwik, the modified form, that is cyanoacrylate. We insert the glue into the fundal varix, it gets hardened and the bleeding stops immediately. It is slightly risky because once you pierce the fundal varix, they can bleed heavily. So it has to be done very fast and smoothly. So doing fundal varix glue injection will save again the patient. The bleeding will stop immediately. Now, if the bleeding does not stop despite a good endoscopist and all modalities have been tried, then you should not feel like not calling any other colleague. You should always take the help of intervention radiologists and surgeons, because it's a team approach. If the endoscopists fail, then comes the role of intervention radiologist and the surgeon. The intervention radiologist has to be called off, he has to be informed prior, he should do a immediate transarterial catheterization, do the angiography, and by coiling or embolization he should close the sealing, he should close the bleeding vessel. And if the intervention radiologist also fail, or if he is not available at your center, then please don't hesitate to call the surgeon and immediately proceed further. So now this is an algorithm. You have a patient of upper GI bleed in an emergency, you take all the history, you all take the blood sample, you start the resuscitations, secure the airways, maintain the circulation, IV line is must, start PPI. If you are suspecting variceal bleed, give somatostatin analogs and call the endoscopist. He will perform an endoscopy based on the degree of bleed. If it is heavy, then urgent endoscopy has to be done. You do the endoscopy, there is active bleed inside, you try all your maneuvers. If you are able to control the bleeding, you discontinue the irrelevant medicines and continue with the PPI or H. pylori indication as indicated. If the endoscopic hemostasis fail, call your colleague of interventionist or surgeon to take on the front seat. If there is no bleed on the endoscopy, nothing heroic to be done, continue with the medical treatment. And if you don't find a source of upper GI bleed on endoscopy, please don't stop, because there may be bleeding in the small bowel. So you always get the other tests done, like CT angiography, CT angiography, colonoscopy, double balloon enteroscopy, to find the exact source of bleed. So what are the take-home message? Upper GI bleed is a very common medical emergency which comes to all the centers. You have to be on your war front to control or salvage these patients. Airway restoration with circulation, with blood fluids, medical treatment in form of PPIs, somatostatin analogs has to be started. There is a role of early endoscopy, call him immediately, and it's a team approach. Alone physician, alone endoscopist will not be able to save the patient. It's a team approach. Surgeon and intervention radiologists are always needed to be informed, because once the things becomes bad, nobody will be able to control. Everybody has to be informed so that the patient can be saved. Thank you.
Thank you, Dr. Saket, for your nice presentation regarding the management of upper GI bleed. I'm interested in knowing, have you come across few cases of spurious hematemesis? Spurious hematemesis.
Sir, spurious, see, you have a lot of patients who have anxiety disorders, and then we have patients who come, they have taken the sundur in their mouth and then vomit it out and put it on the pillow covers. So spurious is basically false hematemesis. So they are malinjuring cases, so that has to be kept in mind always.
But at times it becomes very difficult to diagnose unless
Sir, we have a lot of patients coming to us with these problems. By talking to the patient, you can always make out that the patient may be malinjuring. So you take the history, the patient is sitting stable in your front, the hemoglobin looks okay, and he or she complains that she had a massive upper GI bleed, which is not possible with the vitals maintained stable with a hemoglobin of more than 12. So in those patients, you should always have a suspicion that they may be malnutrition. So sometimes we send that sample to our lab and ask whether it's actually a blood or not. So they do a benzene test and they can make out it's blood or not.
in your practice, how many cases of drug-induced hematemesis you come across?
How many?
Drug-induced hematemesis.
A lot of patients. The majority of the patients nowadays, we have, elderly population, so they are on antiplatelets, they are on NSAIDs for their joint problems. So you have a lot of patients taking these drugs, and these will increase the chances of upper GI bleed. So I think majority of the hospitals have these patients, they have coming to your emergencies with upper GI bleed. So you should always emphasize on what drugs the patient is being on: antiplatelets, NSAIDs, anticoagulants. You have patients of atrial fibrillations, they are on anticoagulants. You have a lot of CVA patients who are taking antiplatelets and anticoagulants. So you should always take a good history of drugs.
But in our practice in emergency, a lot of patients we have come across with the drug-induced hematemesis if we compare with the very serial bleeds.
Yes, sir, definitely. Common scenario, it's a common scenario. You have a lot of patients with drug-induced hematemesis. You should always keep in mind. So, and sometimes you have patients who have consumed insecticides, pesticides. They can even come with upper GI bleed. They have consumed corrosives. They can hide that they have taken a corrosive, and they can come to you with upper GI bleed. And once you insert the scope, you find that the whole esophagus is burned out. And then you go back to the patient, and with their family members, you confirm that he or she has taken any pesticides. And they say, yes, they have taken the Harpic. They were hiding because of the MLC problems.
Thank you. Any questions from audience?
Sir, initially they were being used, but nowadays they've all shifted to PPIs. Nowadays we only use PPIs instead of estrogen receptor antagonists.
You as a gastroenterologist suggest that with NSAIDs and as sir said, many of the drugs causes hematemesis. Do you suggest some preventive PPIs or histamine 2
Yes, sir.
blocking
Any
agents to
patients
be
who are
used?
on prolonged NSAIDs for their joint problems, I will suggest they should take a PPI, maybe at low doses, but they should continue PPI because
Biggest problem with the physician is that in older age group, people are taking several medicines. We have interaction with PPIs and histamine 2 blocking agents.
PPI, they should continue at a low dose with NSAIDs. It is recommended actually. With the antiplatelets, the studies are slightly, diversified. Some says that with the double agent antiplatelets, you can use PPI along with them, but then you should have high risk patients. Any comorbid illnesses, you should always combine the PPI with the double antiplatelet agents like aspirin and clopidogrel. If you are giving, then prefer to give PPI in elderly populations.
What is your impression regarding these raft preparation?
Pardon, sir?
The raft preparation nowadays are floating in the market.
Sir, preparation, see, PPIs, I think it has to be more of personal preference than and then cost. We should not go with the newer and newer PPIs and the cost is increasing. So any person who's taking PPIs just to prevent the side effects, he or should be given advantage of using a cheaper PPI rather than. So still I prefer omeprazole because omeprazole is very cheaply available. So it's better not to go to the higher, newer versions because it will increase the add-on the cost to your prescription. So giving a simple 20 mg omeprazole is sufficient enough rather than, going to the fancy deslansoprazole or esomeprazoles in these patients. We are using it just for prevention of upper GI bleed, not for the treatment. So give a cheaper one. That will be better for the patient because he has to continue it for many years. Sir, when we give IV treatment in patients of these bleeds, we usually prefer to continue for 48 to 72 hours and then we switch over to the oral drugs. You give it for 6 weeks and that will all depend on the scenario actually. What is the reason of upper GI bleed? If it's a peptic ulcer disease, then we'll do a repeat endoscopy and then we'll decide. But if suppose it's a variceal bleed, then you don't need to continue PPI for long because you have done your therapeutic treatment for the variceal bleed and you can stop the PPI. If you have taken a biopsy, it is H. pylori positive, you eradicate the H. pylori, then you can withhold the PPI after 6 to 8 weeks and you can always go back and see the patient is having recurrence of symptoms or not.
What are the harmful effects of use of long-term PPI? People are commonly using.
Renal dysfunction is there.
Especially after the free drugs in government setup, the khali pet wala capsule.
So nowadays with the Google information, all patients come back to you and say, Doctor Sahab, ye nuksan to nahi karegi, maine padha hai ki kidney kharab kar degi. Definitely yes, there are studies which have shown the long-term disadvantages of PPI, parietal atrophy, then you have renal dysfunctions. So we should not use it blindly in all the patients who are coming to your OPD. Sometimes it's even become a habit of us also that writing PPI in all the prescriptions, irrelevant of the disease. Patient is psychosomatic, we write PPI. Patient is dyspepsia, we write PPI. Patient is having unrelated symptoms of GI, we write PPI. PPI and antidepressants and clonazepam has become, the content of the prescription of everybody. Despite any speciality. Everybody is writing, cardiologist is writing PPI, physician is writing PPI, gastroenterologist is writing PPI, everybody is giving PPI. So, slightly if you are judicious with the use of PPIs and prokinetics we write in all the patients. Whether he has got dysmotility symptoms or not, we will always write with prokinetic, Pentosate DSR, OMASD, not the plain PPI. So, we should curtail this habit of writing blanket therapy to all the patients. Yes.
Over the counter we will get.
Available, yes. How does it? Ma'am, small bowel bleeds are uncommon causes of GI bleed. The upper GI and lower GI bleed are more common. But once your endoscopy and colonoscopy are normal, then you should always left with the small bowel bleed. So the patients of small bowel bleed usually comes to you with the features of lower GI bleed. It is uncommon with the ileal bleed to present with hematemesis. They will usually present to you with the blood in stool. So most of the patients will come to you as anemia. They will not get. You are asking about the ileal bleed, no? Yeah. So. I'm coming to that. Small bowel bleeds, when you have patients, then you should always suspect vascular malformations, tumors, and the infections in the small bowel bleed. Any infection that is enteritis can present to you as small bowel bleed. Any infection, whether it is leptospira, it is E. coli, any damn infection can cause enteritis. See, for the bleed to occur, you should have ulcers in the small bowel. And any infection can produce ulcer. So you should always keep in your mind when a patient comes to you, elderly patient coming to you with anemia, You should always suspect if your endoscopy, colonoscopy is normal and the stool local blood is positive, then definitely the lesion is in the small intestine. You go back to the patient, ask the history, whether he has recent features of infective enteritis or not. If not, then you get the CT angiography done, you get the CT enterography done. So see the small bowel. You may find vascular lesions, you may find tumors in the small intestine, which is very common. Patients are, having anemia for last 1 year. They are just hiding it. They are saying that it's because of age. But then after 1 year, the anemia goes, significantly low. The hemoglobin drops to 4 or 5. They get their CT scan done, and they are harboring, carcinoid tumors. They are harboring just in the small intestine. And unless the time has gone, and they may have metastatic disease. So don't take anemia. Don't take anemia in a lighter way, especially in the elderly population. Females can have anemia because of the menses, but male patients don't have anemia usually. So anemia, sometimes you say, our age ho gayi, isliye hemoglobin 9 hai. No, it is not because of age. You should always search and search and search why my hemoglobin is 9, why the patient's hemoglobin is 9. It cannot be normally 9. If you are from good society, you are taking all your meals. Why should you have a hemoglobin of 9 if you are a male patient? It's entirely impossible. You are mistaken, you are missing something.
Hello. How much you consider long-term PPI and osteoporosis? And what is the guideline to take long-term PPI?
This is again
Should we shift on H2 receptor in between?
Yes, sir. Because elderly patients, again, they are exposed to osteoporosis very commonly. So if you are giving PPIs, then in between you should ask the features. The patient is having any bone problems in between or not. They have got a DEXA scan done or not. Their calcium levels or what. They are facing pains in the bones. So try to reduce, and sir has said H2 receptors. Try to shift to H2 receptors if there is no much need of PPI, or try to shift to SOS treatment for PPI.
Take simple oral raft solution and this oral antacid instead of this.
Sir, oral antacids basically will have immediate relief. So they are meant for SOS basis. You cannot take antacids regularly and decrease the acid production. They are just for the immediate symptom relief. They should be used initial severe symptoms for 5-6 days and then shift to SOS basis. You have taken food outside, your whole esophagus and stomach is burning, you take antacid. But try to shift to estrogen receptor antagonist on long-term basis. Try to decrease the PPI. Try to shift to on-demand therapy of PPI. You give a course of 6 to 8 weeks of PPI. Then shift to alternate day of PPI, and then shift to SOS basis of PPI. If the patient is not able to maintain on SOS basis of PPI, then yes, you should start regular PPIs.
Which prokinetic test for long-term use?
Sir, domperidone is slightly on the safer side. The other prokinetics will have, neurological side effects, hormonal disturbances. So prefer domperidone. If not, the patient is not improving, then mozapride you can use. If not improving, then levosulfuride. But always keep a watch over the side effects of levosulfuride. They have akinetic movements, they have loss of libidos. Should always keep, there are menstrual disturbances in the females, which is very common. They have galactorrhea. So you should always keep a watch. Many of the gastroenterologists have seen that using levosulfuride, the female patient develops galactorrhea. And they go to the gynecologist and then they do a prolactin levels, they are increased. Then they refer it to the neurologist get a MRI done. So unnecessary, it was just a side effect of a drug. And you have, a battery of tests has been done by the patient. So you should always keep on asking when you are using prokinetics, ki is tarah ke symptoms to nahi aa rahe. So it can stop the prokinetic and the patient can be saved from unnecessary battery of tests.
Thank you, Dr. Saket.
Thank you, sir. Thank you.
Thank you, Dr. Saket. It was such a nice presentation. And thank you, the esteemed panel of judges. Now, moving forward to the next session of day 2 is Neurology Symposium. And it is going to be presented by Dr. S.P. Patidar. And his topic will be Diabetic Neuropathy and Overview. And to chair the session, I would like to invite Dr. Praveen Gupta, Dr. Gunjan Sharma, Dr. 𝐡𝐤𝐤𝐿, Dr. Munish Maheshwari, and Dr. R.P. Arora. Please have your seat on the dais, please. Dr. R.P. Arora is there? Paediatrics, sir, please come forward.
Dr. Patidar, please start the session.
Yeah. Good morning. Thanks to Dr. Makkar sir and their team for inviting me here. After from this firefighting from blood and disease and death and all kind of the risk, we are going to cool topic, chronic topic, relaxed topic, diabetic neuropathy. So from here hot dal, we are going to cool coconut ice cream. This is diabetic neuropathy. As the whole audience are here, physicians, senior physicians and roaring practitioners, they all encounter diabetic patient with neuropathy in day-to-day their practices. So this is very useful for them. Our topic will be restricted to the pathophysiology, what are the mechanism of diabetic neuropathy, how to diagnose the diabetic neuropathy clinically as well as electrophysiologically, and we outline the newer management of the diabetic neuropathy. So let's start with the diabetic neuropathy. Diabetic neuropathy is a syndrome comprising of series of separate clinical symptoms, from small fiber neuropathy to large fiber neuropathy, from burning sensation to tingling to numbness to ataxia, from cardiac rate abnormality, means autonomic nervous system dysfunction, from postural hypotension to simple sleeping of the sleepers. So it's a various kind of series of the separate clinical disorders. How common is? As you all know, diabetic neuropathy is most common complication in diabetic patients, especially in chronic diabetic patients, it's the most common. In type 2 and type 1, as the study says, 59% of the type 2 patients will suffer from diabetic neuropathy and 66% in type 1. At the onset of type 2 diabetes, as you all know, we can diagnose, we can see the patient with neuropathy at that time also. First diagnosed with a sugar of 300 or 400, HbA1c in the range of 8 or 9. First time diagnosed and having the symptoms of tingling, numbness in the feet and the hand. So, in the type 2 patients, we may have neuropathy symptoms at the onset of the disease. In contrast to type 1 patients, younger patients, insulin dependents, they cannot be dormant for longer times. So, diabetic neuropathy will diagnose in later stage of the type 1 patients. But in type 2, we have to aware about the diabetic neuropathy in the onset also. So, in contrast to diabetic with neuropathy relation, we can say diabetic neuropathy is the most common neuropathy studied in till research in the all medical history. So both are common. Diabetic neuropathy having most common complication in diabetes, and diabetic neuropathy is the most common neuropathy in the medical field. So this is the, you can say, official definition of the diabetic neuropathy. You all know about this. So what are the risk factors of diabetic neuropathy? How it develops? So some modifiable risk factors, as in cardiac disease, we see some modifiable, some non-modifiable. So some modifiable risk factors are uncontrolled diabetes, alcohol consumptions, uncontrolled hypertension, smoking, hypertriglyceridemia, and obesity. In non-modifiable risk factors, we can see these are the common non-modifiable risk factors. How it is set in? So there is lots of controversy about the pathogenesis of the diabetic neuropathy. Previously, these all our mechanisms are proposed till 2012, but after that, the pathogenesis moved down to mitochondrial dysfunction. So I'm describing it, previous mechanisms like aldol's reductase activity, auto-oxidation of the glucose, AGE level, PKC level, some oxidative stress. Now ischemia after vasculitis or diabetic vasculitis is also common at that time. This is a very busy slide about the glycation and their damage. The most important is that here, glycation leads to nerve and vessel wall dysfunction. This is end result. This parameter is most important for the glycation pathway. But later on it changed. So hyperglycemia and glycemic variability in various pathway results in sorbitol pathway and leads to neuropathy. So this is the new consensus. What is the pathogenesis? The energy depletion of the nerve is very important. Mitochondria is the energy center of the cell. You all know that the neuron cell is far away from the nerve. And axon is traveling from lumbar radical to the great toe. This is the longest fiber. So mitochondria generating energy in the cell body, and it has to be traveled to the longest nerve fiber. So as the fiber become lengther and lengther, then the energy depletion will be more and more. Some mitochondria from the cell body is also moved from the axons to some extent till the larger diameters. So this is the new concept that glycemic control itself cannot prevent the progression of diabetic neuropathy in type 2 patients. Cannot. So metabolic syndromes emerge in crucial risk factor of the diabetic neuropathy. Metabolic syndrome means you all know about obesity, hyperglycemia, hypertension, alcohol, all kind of the wastage ratio parameters. So these are also major risk factor apart from sugar control of the diabetic neuropathy. This is the chain of event, how the diabetic neuropathy set in. So obesity and insulin resistant, hyperglycemia, then bioenergetic failure, mitochondrial depolarization, inflammation, apoptosis, these all are the interlinked mechanisms. So because of the fewer functional mitochondria successfully travel the long distance from cell, it become energy depletion later stages. In the small fiber and large fiber differences, two type of the fibers are there, that delta fibers, A delta fibers and small fibers, C fibers. So these are non-myelinated or thinly myelinated fibers. Myelin is the cell which cover the nerves. In the large fiber, they have richly sewn cell protection and knots of Ranviers are there. In the small fiber, this energy depletion occurs earlier because there is no support from the myelin. One factor is there. So why the small fiber symptoms came earlier? Because they are energy depletion earlier in the stage of the diabetes. So when they energy deplete, their you can say axonal degeneration will be there. Second risk factor is there. They are exposed to the hyperglycemic environment more than the large fiber because protection layer of the knots of Ranvier is not there in them. So small fiber is earlier to damage and large fiber later in the scenario in the diabetic neuropathy. So in diabetic environment, excess glucose and lipid not only disrupt the normal pathway, must break down, but the mitochondrial dysfunction is important. The bioenergetic failure and loss of normal mitochondrial membrane like depolarization, extra electron, then reagent of the oxidative stress they occurred. So endoplasmic reticulum stress, apoptosis, new degeneration is there. So this is the mechanisms. After this mechanism, we came on to the clinical scenario, how we classify the diabetic neuropathy. These are the classification, the most common generalized symmetrical polyneuropathies, focal symmetrical, focal asymmetrical, and combinations. This is old picture from our from MBBS days. So about the one important acute sensory neuropathy. You all know about the distal symmetrical peripheral neuropathy from age old. So acute, what is the acute sensory neuropathy? This is, as the name shows, its onset is very acute. So burning discomfort in the feet, hyperesthesia, deep aching pain, Sharp, shooting pains are there, loss of sleep is there, weight loss is there, loss of appetite is there, severe allodynia, even non-painful stimuli can lead to pain in their patients. Maybe diagnosed in first stage when they're diagnosed in the diabetes. So it's a rare disease, but well recognized distinct entity from the other sensory neuropathies. Why it is separate entity? Because it's not because of the axonal degeneration or apoptosis or the oxidative stress. It's because only and only because of the hyperglycemia. So it is reversible also. So it is characterized by severe neuropathic symptoms. Typically occur sudden change in the glycemic control. Sometimes when you see the transplant patients, sometimes we see the patients who left their OHAs or insulin, suddenly sharp rise in the blood sugar because of some non-allopathic medicine. They shift to the non-allopathic medicine and sugar rises sharply. And they came with the high sugar with neuropathy symptoms. 1 month back, they were absolutely stable. Sugar control was there. There was no neuropathic symptoms. Now you are seeing acute neuropathic symptoms and hyperglycemia. So it may occur with the sudden change in the glycemic control. So it can also follow with the ketoacidosis, especially in type 1 diabetic patients or type 2 where the infection or some other stage. Ketoacidosis may also lead to sudden, you can say acute painful neuropathy. The prognosis of this acute painful neuropathy is very good. Typically resolves the symptoms within 12 months if the blood sugar is controlled. So previously it was called insulin neuritis or some other names, but now the treatment-induced neuropathy of diabetes is the final term given for the acute neuropathy. Second is chronic sensory neuropathy. This is the most common one. Almost 3/4 of the diabetic patients suffer from distal symmetrical neuropathy. Sensory dominant because of the small fiber involvement, sensory and autonomic minor involvement of the distal muscles, sensory stalk and glove pattern, length dependent, and advanced sensation impaired or chest and abdomen, waist-shaped area in later stages. In the large fiber neuropathy, you all know myelinated thick fibers are there, later involved. So position sense, vibration, and fine touch. These are the large fiber sensation that involve, leads to ataxia. These are also symmetrical polyneuropathy patterns, Charcot joints and all that. What are the clinicians should aware? This is very important. Clinicians should also be aware that the half of the diabetic patients in DPN may either say symptomatic or reluctant to report the symptoms. Sometimes we see that patient is not having neuropathy, but sometime on leading the questions, are you having any tingling in your feet? Are you having any ataxia in walking? Are you having sleeping of sleeper? Then they came out with the symptoms. Yes, I am having these symptoms. So during routine examination, we have to ask about these symptoms also. Sometimes individuals become asymptomatic later on. Means patient was having tingling, burning, all kind of the sensation was there, but later on they disappeared without any treatment or with some pregabalin or so. So this is not a good sign. Always it's not a good sign. Disappearance of the tingling, pricking sensation or burning may indicate that the nerve fiber are now not working. Means numbness is the lesser noticed by the patient because it's a negative symptom. Positive symptom, pain or tingling or burning is easily understood by the patient. It is a daily complaints, but numbness will not. So previously patient is having pricking sensation or tingling and now not having no complaint. Means we have to go to the foot, see the vibration sense or joint position sense or final monofilament test to see any numbness is there because it's very important. Diabetic foot is the most common complication in these kind of the patients. So we have to aware that the disappearance of the burning and tingling is not the good sign always. So beware about it. Patient will not complain definitely for it. So what are the protocols for screening of diabetic neuropathy patients? As you know, HbA1c should be done every 3 months or 6 months, thyroid profile should be done. So there is a protocol also. So it's annually testing should be there for type 2 in first 5 years of the type 1 diabetes mellitus patient. Pre-diabetic patients like HbA1c less than 6.5 should be screened for the diabetic peripheral neuropathy, and that's an indication for the starting of the treatment also. Assessment should be done detailed history, and I will later on the clinical examinations. Electrophysiological testing is only needed in people with atypical signs and symptoms. It's not the neuroconduction study which will let you know about the diabetic neuropathy. You all can diagnose diabetic neuropathy within few minutes that patient is having small fiber or large fiber neuropathy to such extent and such extent. It's progressing or not progressing, every 6 months you can examine. So neurological diagnostic electrophysiological study is not required in typical patients. When you see some atypical signs is there, rapidly growing symptoms are there, or symptoms are regressing rapidly, or patient is having recurrent fall, autonomic nervous dysfunction, then you can go for the electrodiagnostics test. So, electrodiagnosis, as you know, neuroconduction will show decrease or absence of the SNAP, low amplitude H reflex, decreased CMAP amplitude. These are all typical findings of the electrodiagnostics test. One important, you can say, apart from the diabetic distal symmetry neuropathy, one important is the relation of the diabetic patient with CIDP. Chronic inflammatory demyelinating polyneuropathy. It's an autoimmune disorder. Very much controversy is there about the diagnosis of diabetic neuropathy and CIDP. We can see CIDP is subacute to chronic onset. Diabetic is later chronic and slow onset. Apart from this, CIDP having a good response with the immunomodulator drugs. So don't miss the CIDP in diabetic neuropathy patients. Because sometimes we see neuropathy is there, sleeping of sleeper is there, ataxia is there, weakness is there. We say it's a diabetic patient, so neuropathy will be of the diabetic type. But beware of the CIDP. If the symptoms are increasing rapidly or large fiber is more involved than the small fiber, then think about the CIDP because it's a very well treatable disorder. Diabetic is only manageable disorder. So it's a very strong relation between CIDP and diabetic patients. This is the one study which is showing diabetic and non-diabetic patients having very good relation. Sorry. This is diabetic patient having CIDP and this is normal population having CIDP. So it's a very common disorder in diabetic patients. So beware of it also. Electrodiagnosis will help definitely in CIDP diagnosis. Now come on to the autoimmune neuropathy. Autoimmune neuropathy, as you'll know, is thinly myelinated fibers, small fibers, C fibers. So they are also involved in early stage of the disease. But sometimes it's misdiagnosed. Like in GI symptoms, very common fullness of the upper epigastric fullness is very common complaint in all the patients. We give domperidone, levosulpiride, and you can say Dr. Saket is saying mesopride and all prokinetic drugs. But it may be starting of the autonomic neuropathy because of the gastric emptying is delayed in diabetic patients. So beware about think about the diabetic autonomic neuropathy in such symptoms like some urgency urine, sometime difficulty in defecation like constipation. Or we think about the BPH first rather than having in mind that autonomic neuropathy may set in and may lead to the bladder wall dysfunction. So this should be keep in mind when dealing with the diabetic patients in neuropathy. These are the various symptoms of the autonomic neuropathies. How to diagnose the autonomic neuropathy? I'm skipping these slides. So, mononeuritis multiplex and cranial neuropathy is also common. These are also not so common. So this is very important. Is it diabetic neuropathy or neuropathy in diabetic patients? Unrelated neuropathy in diabetic patient is 30%. Diabetic patient having neuropathy is very common. Neuropathy of the most common type is diabetic neuropathy, point taken. In diabetic patient, 30% of the neuropathy is non-diabetic related. Keep in mind. So how to think of that? Because this is alarming sign. Every diabetic patient, even patient can Google himself and say diabetic neuropathy ho gaya sir mere to. Because 5 years of the diabetes there, so glycemic control was plus minus, so I am having diabetic neuropathy. So being a clinician, being a physician, you have to focus on few points. When you keep in mind that it's a non-diabetic neuropathy in diabetic patient. So points are, if the neuropathy is rapidly progressive, think of the non-diabetic neuropathy. Prominent motor abnormalities Rather than sensory, if patient is having more complaint of the sleeping or sleeper, difficulty in breaking chapatis, difficulty in getting up from the sitting position, think about the non-diabetic neuropathy first. It may be diabetic also, but keep in mind that it may be non-diabetic also. Disproportionate large fiber abnormalities, involvement of the entire lower limb without neuropathy in the distal upper limb. As you know, glove and stocking was the term used in MBBS days. When the neuropathy reaches to the knees, the upper limb, finger toes will start tingling. So, if the whole lower limb is involved, up to the thigh, up to the waist, but there is no tingling in upper limb, means it's not the diabetic neuropathy, it's something else. So, we think about some other disorder like radiculopathy or lumboplexusopathy or some other abnormalities. What are these things to be keep in mind? Important points I have written here. Metabolic disease, thyroid and renal disease, CIDP is already discussed, alcohol intake, amiodarone, codron intake, some chemotherapy in cancer patients, vasculitic risk factor, paraproteinemia is very important nowadays, amyloidosis, underdiagnosed disease, amyloidosis is very common, but it's underdiagnosed. Some vitamin deficiencies, nutritional deficiencies are also there, commonly is B12 and B1. Heavy metals, arsenic and mercury, HIV, hepatitis B and Lyme disease, some industrial agents in especially industrial workers, some hereditary and genetic. So these are the clinical signs. Abrupt, asymmetrical, motor than sensory, large and small fibers, very selective involvement, pes cavus and hamartos. You can examine these very well in your clinical scenario. If the pes cavus is there and hamartos is there, just think about the genetic neuropathies, hereditary neuropathies. Very less symptoms, almost asymptomatic, having hamartos and pes cavus is there, by and large having hereditary neuropathies until proved otherwise. So you can examine pes cavus and hamartos. Even they will not give the family history also, because there are unaware family members. Monoclonal gammopathy, CSF protein is very important when you do CSF. More than 100 gram in diabetic patients, when we see the CSF examination normal, 45 gram is the normal, but 45 to 100 can be available in the diabetic patients also. So there is confusion about the protein level in CSF. But if level is more than 100, just think of the non-diabetic neuropathy. Elevated ES are unrelated to osteoarthritis or other symptoms, unexplained by RF positive and ANA positive. So these are the how to approach. Now we are going to the clinical approach of the patients with the diabetic neuropathy. So diagnosing a diabetic neuropathy is as simple as diagnosing the diabetes itself. If you are aware, if you are interested in asking 2, 3, 4 questions to the patient and examine 2, 3 times, diabetic neuropathy will be diagnosed within 5 minutes, like the diabetes itself. So what are the questions? We should ask about the long duration of the diabetes. We see older patients, metabolic syndromes, hyperlipidemia, tall stature, social abnormalities like poor socioeconomic status and nutritional values, frequent falls. So assess for the diabetic neuropathy. If yes, then go for the clinical signs. Reduce or absent pinprick sensation. First time the loss will be the pinprick, pain sensation, small fiber. Always remember small fiber will involve initially. Then reduce the cold and temperature. These are also A delta fibers. If yes, then it's a diabetic neuropathy is present. Then the symptoms of the large fiber are there like numbness, poorly balanced, weakness. These are the large fiber symptoms. So think about the differential diagnosis in your mind. If there is no differential diagnosis, the factors are all clear, then if no, then treat according to the underlying condition. Very rarely you want to refer to the patient to the neurologist when the diagnosis is very much confusing. It's very uncommon to refer a diabetic neuropathy patient to the neurologist. Very rare. Some common devices are there. You will know about the monofilament, tuning fork. Easy to available monofilament is the 10 gram neurofilament you use here. 10 gram means the monofilament is having strength that when we put 10 gram weight onto the monofilament, it should be buccal. It should not be more than that strong. So it's a monofilament test. Tuning fork, graduated tuning fork, we can use the normal tuning fork also for the vibration test. These are the pain we can use in the clinical scenario. Electrophysiology has already been discussed. I'm skipping this diabetic neuropathy control. The most important is that We are going to the management slide because we are in short of time. Yeah, this is a summary of the treatment of the. The important thing is that glycemic control you all know very well. But fluctuation in the glycemic control is very important. We all see HbA1c, भाई इसका तो 7 आ रहा है, ठीक है तो. No, it's not like that. If the sugar is going 400 to 75, up and down is there, then the neuropathy will set in definitely, although HbA1c is 6.5 or 7. So fluctuation in the blood glucose level should be controlled rather than monitoring only the HbA1c for the diabetic neuropathy purposes. Only pregabalin is there which is having level A approval from FDA, from the studies. Other all medicines are in level B like gabapentin, valproate, venlafaxine, duloxetine, amitriptyline, dextromethorphan and other. Tramadol should be avoided because of the addiction purposes. It should be kept for the emergency only. Autonomic manifestation. So what is the summary? Effective pharmacological therapies of the painful diabetic neuropathy like anti-epileptics, pregabalin, gabapentin, duloxetine and tricyclic, these are available very well in the market. Although often effective, these are effective medicines in pain reduction but require higher doses, maybe less tolerated and higher incidence of the adverse effects. You know, in elderly population, starting vertigo, recurrent fall, dizziness, more and more sleepiness. So high doses are not very well tolerated. So in this scenario, we can use the lower dose combination medicines. If the pregabalin you are giving 75 and 150 start dizziness, you can decrease to the 75 again and add lower dose some other medicine like antidepressant, duloxetine or amitriptyline or nortriptyline or carbamazepine. Rather than increasing the dose of the pregabalin, lower dose of the two medicine, under dose of the two medicine will work definitely and side effect profile will be set, especially in older population. What is unmet need? Because the efficacy both, because you can say random RCT is not possible in diabetic neuropathy patient because it's a long term. The outcome is not definite. Blood sugar control criteria is not definite. So RCT is not available in the diabetic neuropathy patients. Because of the efficacy of both causal therapy and diabetic peripheral neuropathy, symptomatic treatment is only available, but it's limited. So there is unmet need of the holistic approach considering pathogenically oriented adjunctive therapy, which leads to the, you can say, energy depletion should be decreased rather than the symptomatic treatment, but it's not available unfortunately right now. Based on the evidence for the efficacy in reduction of the symptoms of the excellent safety in RCTs, ALA and benfotiamine, currently approved in some countries but not by the FDA, may be added to the pain in the diabetic. So many medicines having combination of benfotiamine and ALA. So this is the bottom line for their studies. Can be added, not approved by the FDA. Although it's available in market. Confirmatory RCTs will clarify available. So what is the take-home message? Diabetic neuropathy occurs in more than 50% of the patients with diabetes. Metabolic and vascular factors are implicated in pathogenesis. Most common type you have very well know DSPN. Exclude non-diabetic etiologies by the clinical features only, no further tests required. Stabilize glycemic control. Not only glycemic control, stabilize the glycemic control. Tricyclic, anticonvulsant should be given maximum possible doses. And opioids and opioid-like drugs like tramadol and control should be avoided for the addiction purposes and their side effects. Drug targeting pathogenic process are in development and may be available in near future. These are the references. Thank you.
Questions from audience?
Any role? No, sir. Palmitol is there in no role. These are all, you can say, antioxidant, protective drugs, but there is no proven role of the any drug apart from two benfotiamine and ALL. That's all. And these are also only not FDA approved. Benfotiamine, I have seen the ALA and benfotiamine is also not FDA approved. We are using here, but it's not available in India. Not available in many countries, but not FDA approved. No, any other medicine is approved.
Because Pulmonology is largely used by many doctors in the practice. At least I am using it.
Are you?
Palmitol is a drug which is used since many years by me and by many doctors. It is marketed by many companies, Palmitol.
Maybe, sir. Marketed by the companies and so many other components are there. I skipped those
So
slides.
you are not used in your practice, sir?
No, we are not using, sir.
Okay.
Benfotiamine and ALA, alpha-levulinic acid. Two are not FDA approved, but useful in some RCTs, may be approved by FDA in future years, coming years, we can say.
There is specific rationale of using such type of drugs.
Yeah.
Because we see in the prescription, even the most of the neurologists, that they are prescribing from initial stage, where there are not gross symptoms of neuropathy in a particular patient. Does these things helps in prevention, or this is a conventional practice adopted?
Exactly, sir, exactly. This is the only become a fashion of giving pregabalin to all diabetic patients. It's not like that. Some symptoms like tingling, non-disturbing, sleep is normal, some neuropathies are no need of treatment. Just glycemic control is sufficient. Some local capsaicin, local 𝐡𝐤𝐥𝐻 gels may be sufficient for the patient for the night time only. Why to prescribe pregabalin in early stage of the disease? Even you are right, 50% of the patient doesn't require any medicine in diabetic neuropathy patient. They can tolerate very well.
Many times high doses of B12 are also being prescribed. So it has become the part of treatment because they have been combined with, pregabalin or
If the deficiency of B12 is there, then it should be, you can say, given, but not in umbrella therapy like. In
diabetic neuropathy, B12 levels should be assessed first and then
Yes, exactly. Even non-diabetic also. Why you prescribe neurokind OD in every patient? Even patient himself is taking B12, by मैं तो pure vegetarian B12 खा लो, without assessing the level. So level assessment should be there to rational the dose duration and the what should dose be there, how we are monitoring, just giving B12. No, sir. NSAIDs are not there. NSAID is having different kind of the anti-inflammatory mechanisms, like they are working on the prostaglandin 1 and 2 receptors, which is not mechanism here. There is a polyol pathway, different kind of the aldose reductase pathway here, which is not working, not tackled by the NSAIDs.
Hello. What do you think about reversal of diabetic neuropathy, like reversal of diabetes? When patient come to you with the first time diagnosed as diabetes, he always asks, कितने दिन दवाई लेनी पड़ेगी, कब तक लेनी पड़ेगी diabetes की? Simply when patient come to with the diabetic neuropathy, he will also ask कि कब तक लेनी पड़ेगी, ये ठीक तो हो जाएगी ना? So what do you think about reversal of this diabetic neuropathy? And second thing, how you treat the diabetic autonomopathy who has recurrent fall with postural hypotension?
The first question is reversal of the diabetic neuropathy. Very few kind of the neuropathies are there that can be reversed. You can say acute painful neuropathy can be reversed, even with the diabetes also. If you are saying that diabetes is reversed by other mechanism, like you can say some other medicine, exercises, dietary management, or obesity surgeries, or so many things are there. But diabetic neuropathy will not reverse. Neuropathy will remain there because it is the irreversible damage. Diabetes may or may not, very well, can be reversed, but diabetic neuropathy will not, by and large. The second question about the postural hypotension. I'm thinking you are about the postural hypotension. Yeah, recurrent falls. Recurrent fall in diabetic patients can occur because of the numbness in the feet also, can occur because of the postural hypotension also. We have to assess the patient in clinical history what is the cause of fall. By Romberg sign, we can say just 30-second sign will tell you what is the etiology. Just lie down the patient for 3 minutes, measure the blood pressure, get up. After 3 minutes and 5 minutes and 10 minutes, we can measure the heart rate and the blood pressure, which will be very enough for the autonomic testing. For the management, it's very difficult to manage the autonomic dysfunction in diabetic patients, everywhere. Autonomic is the worst kind of the neuropathies. But we can say lots of fluid intake, if the permitted by the cardiologist and nephrologist, if diseases are not there from the nephro and cardio side, we can take ask him to take the lots of fluid. Slow change in the posture, because give some time to the adrenergic system to settle down to prevent the fall of the blood pressure suddenly. The third thing is some medicines are available, like midodrine is there now available. Is the 5 milligram BD. Yes, midodrive is the very good medicine, but the major side effect, you can say practical side effect of the midodrive is, apart from cost and all the things, that lying down hypertension will be there. Supine hypertension is the major side effect of the midodrive. So it leads to other cardiac abnormalities and intracranial abnormality like ICH and all the things. So beware of giving midodrive. 5 milligrams, just start from the 2.5 milligram, increase to 2.5 milligram BD, then 5 milligram BD if the response is not there. And don't give the medicine in evening hours. If you are giving BD midodrive, then give morning 6 a.m. or 7 a.m. or 8 a.m. when you get up from the bed, and second dose at the 3 p.m. or 4 p.m. Don't give it the 8 p.m. or 9 p.m. So supine hypertension will be taken care of that because of that. Atomoxetine is also approved for that. Yes, ma'am. Cramps and fibromyalgia, both are different things. Cramps is the hyperactivity of the muscle fibers that spontaneously, you can say, generating the CMAP potentials. Cramp is generated from the muscle, it's very well originate side. So, cramp having multiple etiologies, not diabetic only. Cramp may occur in the normal population, hypocalcemia, even in diabetes also. In the normal population, like RLS patient, PLMS patient, they having cramps in the night time. So cramp can be taken off the lots of fluid intake, I am just asked, dietary manifestation, early dinner, and sometime pregabalin also can be given for shorter time for the cramps. Fibromyalgia, rotator cuff weakness or what? Fibromyalgia is the diffused pain basically. Scapular area and there's elbow and these are. Fibromyalgia, difficult to diagnose and more difficult to treat. Sometimes they need many sessions, pregabalin, antidepressant, painkillers, still no response. Some require counseling, some have to adjust with the fibromyalgia pain. Fibromyalgia, needling is required sometime, but fibromyalgia is difficult to treat.
सर अल्फा लिपोइक एसिड जो कॉमनली प्रिपरेशन होते हैं इनमें यूज होता है, क्या वो हाइपोग्लाइसेमिया करता है?
नो.
इंसुलिन ऑटो इम्यून सिंड्रोम के साथ एसोसिएटेड है सर वो?
ALA with autoimmune
कितना कॉमन है वो क्लिनिकल?
No, I am not aware of that. No sir, no sir. These all are combination medicines available here. From carnivore to leke, sub available. Nothing is a helper. Yes, HbA1c, as you more better knows than us, because HbA1c less than 7 is very good. But rather than only HbA1c in target, we should prevent the fluctuation of the blood sugar, because in 3 months, sometime 400, sometimes 75, HbA1c will be normal.
Hello.
But it's a fluctuation. We should prevent of the fluctuation.
Thank you, Dr. Patidar. And now we start next session.
Thanks a lot, Dr. S.P. Patidar, and I am very much sure that you have learnt a lot from his knowledge and wisdom. Coming forward to the next session, which is on structural heart disease in cardiology. So, to chair the session, I would like to invite Dr. Ajay Singh Rathore sir, Dr. S.S. Singh sir, Dr. V.K. Jain sir, Dr. P.C. Ranka sir, Dr. S.S. Daria sir, Dr. Prem Ratan Dagawat, and Dr. Prashant Dwivedi. Now I would like to invite organizing chairman Dr. Jiten Singh Makkar sir to give an insight of how we are doing in structural heart disease at Eternal Hospital. He will give you a brief introduction regarding it. Sir, please.
Good morning, everyone. Good morning, respected chairpersons. Just before the lecture starts, I just want to brief about what is structural heart disease and what is this all about and what our team is doing right now. So I think this is the latest addition in cardiology curriculum, the structural heart disease. Even when I was doing MD, DM back in 2000, 2001, this terminology was not there, structural heart disease. There were valvular intervention, but later on this came up as specialty, and it includes all the valvular disease interventions, like latest being the tower and tricuspid and mitral valve replacement, repairs, and ASD, VSD closures, hypertrophic cardiomyopathy, alcohol septal ablation. All these kinds of procedures are included under structural heart disease, LA appendage occluder for atrial fibrillation patient. So we have an eminent team, which is of course led by our chairman and promoter, Dr. Samin Sharma, who himself is a renowned interventionist and structural heart disease specialist. But we have two very young, enthusiastic, skilled, learned gentlemen, Dr. Prashant Dwivedi, who is director of our structural heart disease. So he has been trained at Mount Sinai for complex intervention and structural heart disease fellowship. And Dr. Prem Ratan Degawat, who has been trained after his DM for structural heart disease interventions and peripheral interventions and at Italy and Dr. Antonio Colombo Center. So with two structural heart disease specialists being there, it's a teamwork and a very excellent surgical and cardiac anesthetic support is there at ESCC that everybody knows, led by Dr. Bana and Dr. Navneet Mehta. So it and you know, structural heart disease interventions are related with arrhythmias, bradyarrhythmias that they will cover in their topic also probably. So a strong EP team is also backing up them. So I think it makes a unique team, and I would say to all of our physicians who are sitting there, if you have some valvular disease patient or ASD, VSD or hypertrophic cardiomyopathy patient who you think requires some kind of intervention, I think that's the perfect scenario where your patient can obtain the best possible care, because it is a team effort. Not even any procedure is a team effort. It's not a single man's effort, and we have very good team to do that at Eternal. So with this, I'll request chairs to invite the speaker. Thank you so much.
We should start with the presentation first. Okay, welcome. As far as the structural valvular disease, when we were doing MD in year 75, 76, 77, it used to be a long case many a times. And valvular disease, you know, the cases were collected from different places to be presented before the MD examination. The treatment era and knowledge transformation has gone to this extent. Now they are not doing open heart surgery, rather than intravascular implant of the valve. So it will be really an interesting learning for we all.
Thank you, sir. First of all, I would like to emphasize that Dr. Makkar is always there for us as a teacher, as a mentor, and as a guide. So it's not only about the cardiology, even for our life, he's like a big support for us. So in next few minutes, I am going to talk about the non-surgical intervention in aortic valve disease. So when we talk about the structural heart disease, as Dr. Makkar already says that it's not only the valvular heart disease, it includes the many varieties of intervention. It includes the closing of the halls like ASD, VSD, PDA, coactoplasty, then left atrial appendage closure, alcohol septal ablation, BAB, BPB, BMB, and then the newer advanced intervention like transcatheter aortic valve replacement, mitral valve replacement, transcatheter tricuspid and pulmonary valve replacement without open heart surgery. So the last 20 years has been a remarkable period for innovation, and the innovation came in so long that now we can replace almost every valve, or we can repair almost every valve without open heart surgery. But the patient selection has to be proper, and it has to be through the heart team evaluation. It's not about that the cardiologist has to do, so he should do the procedure. It should be the discussion with the cardiologist, cardiac surgeon, and cardiac anesthesia, and then we decide which patient required which therapy and which therapy is best for that patient. So for the aortic valve perspective, I'm going to start with this question. So just a quick question for everyone. Which one has the best prognosis? That is a maximum 5-year survival. It's a prostate cancer, breast cancer, ovary cancer, colorectal cancer, lung cancer, or symptomatic aortic stenosis. Which one has the best prognosis? So the answer is prostate cancer. So prostate cancer has the highest survival rate compared to all other cancer. So now the question is, which one has the worst prognosis? That is minimum 5-year survival if it's untreated. Sorry? Yes. So the symptomatic aortic stenosis is having a worse survival. So the survival rate of untreated severe aortic stenosis is worse than a lot of metastatic cancer, including lung, breast, prostate, ovary, and the colorectal cancer. That's why it's very important to get to know when the patient is having a severe aortic stenosis, and once he becomes symptomatic, he should go for a proper treatment at the proper time. So let me start with a case of aortic stenosis. It was a 75-year young male. I'm talking about a young male because most of the patient, the severe aortic stenosis, most of the patient developed after 60, 65 years. 75 years is still the young patient for us because most of the patients are above 80 years of the age. We did one of the oldest patient in India, the transcatheter aortic valve replacement at the age of 104 years, and that is the third oldest patient in India. So this was a 75-year young male patient presented in emergency in a gasping state with a heart rate of 120 per minute, and the blood pressure was 70 millimeter of systolic, and the saturation on admission was 50%. AVG shows metabolic acidosis, pH was 7.14, found to be in acute decompensated heart failure and cardiac shock, NYHA class 4. Patient was immediately resuscitated in the emergency, intubated, kept on ventilator, and high-dose vasopressor, including NORAD of 20 and dopamine of 20. Soda bicarb and other supportive treatment were given. ECG shows left ventricular hypertrophy with STT changes with bifascicular block. Echo shows severe aortic stenosis with a valve area of 0.3, and the EF was 20% only. Creatinine was 2.1. Echo shows a severe aortic stenosis with a mean gradient of 84. So whenever the gradient is more than 60, it is considered as a critical aortic stenosis. So after 24 hours in ICU, patient becomes conscious, alert, but is still on ventilator. Blood pressure is 100/70, but is still on high-dose vasopressor support. After 5 days in ICU, patient is conscious, alert, but is still on ventilator. Blood pressure is 170, but is still on high-dose vasopressor. And patient is unable to wean from the inotropic support and unable to extubate for last 5 days. So what should be done next to bring him out of ICU? So being a critical aortic stenosis, that's a mechanical problem. So the mechanical problem can be treated only once we fix that mechanical problem. So patient will not survive until the aortic valve open. So surgical consultation was done for surgical AVR, but due to advanced age, low ejection fraction, and the cardiogenic shock, very high risk for surgery, so the patient was denied for surgery. So what to do now? So until few years back, these patients used to die without any intervention or surgery because we didn't have any option for them. So if you look at the prevalence of valvular heart disease by age, as the age advances, especially after the age of 55 to 64 years, the prevalence of valvular heart disease increases exponentially. So by the age of 55 to 60 years, the prevalence is around 2 to 3%, while at the age of 65 to 74 years, the prevalence is up to 8%, and by 75 years, it's around 13 to 14%. We all know about the prevalence of rheumatic heart disease. India and Southeast Asia countries are the major bulk of prevalence of rheumatic heart disease, while in the Western world it's hardly 0.3%. Though the new data is coming after this cleanness and a decrease in the prevalence of rheumatic heart disease has been reported in Indian subcontinent also. So what if the patient with severe aortic stenosis doesn't replace valve timely? So whenever a patient develops a symptomatic severe aortic stenosis, there is most of the time there is a latent period, a long latent period. Over that period, patient had developed increasing obstruction as well as increased myocardial overload. But once the patient becomes started symptoms, either in the form of angina or a dyspnea or in the form of syncope, then there is a rapid downhill course. Because if the patient, once the patient start developing symptoms, there is a 2-year survival after once the patient developed congestive heart failure, 3-year survival if the patient develops syncope, and the 5-year survival after once the patient developed starting angina. So what about if these patients are being managed medically? So if in a medically managed patient, the chances of 5-year survival is hardly less than 10%. So most of the patients die without any intervention if we treat these patients medically. So without proper and timely intervention, severe aortic stenosis patients die within a period of 2 years. So that's why the prognosis of these severe aortic stenosis, symptomatic severe aortic stenosis, is worse than most of the other critical cancers and metastatic cancers. So what if the patient with severe aortic stenosis replace valve timely? So if the patient of the severe aortic stenosis patient, once he develops symptoms, if he get the intervention timely, the natural history becomes like this. So it will be like on a plateau phase. So patient survival improves. So that's why the timely intervention and timely diagnosis for the severe aortic stenosis is very important. So the pioneer in this therapy was the Alan Crever. He is considered as the father of structural cardiology. He died recently on 16th of February 2024. I was fortunate to meet him and had his guidance. So it was April 16, 2002 when dream came to reality, when he did the first in man transcatheter aortic valve replacement in a patient who was about to die, surgically turned down, and patient was refused for surgery. And in that patient, he did the transcatheter first aortic replacement without open heart surgery. And that patient shows a spectacular clinical improvement. Since then, the therapy has advanced so long. And now let's come back to our patient. So in our patient, what we did a heart team discussion with cardiologist, cardiac surgeon, cardiac anesthesia, and we decided to go ahead with a rescue transcatheter aortic valve replacement. So rescue tower is something like in a patient with a cardiogenic shock, we are doing something like a primary PCI. So family was counseled and they were agreed for the procedure. Cardiac CT was done and analyzed and planned accordingly. This is what we do, the cardiac CT scan. We analyze and we decide what kind of valve, what type of valve, and what size of valve is the best for the patient. So we always do the coronary angiogram in each and every patient to rule out any coronary obstruction so that we can fix it at the same time. So the coronary angiogram shows the normal coronaries without any significant obstruction. So then we initially took the left groin axis, and then we took a left groin axis. We did the angiogram on the left groin, and then we put a large sheath across the left groin from the common femoral artery. Then we take the aortogram picture of the aortic valve, and then we cross the aortic valve through the wires. And over those stiff wire, we do the pre-dilatation with a balloon. So you can see how severe and calcified is the valve, and it was difficult to even open the valve with the balloon. So after that, we positioned the valve and we deployed the valve under a rapid pacing of 180 per minute. And then this is the final result. Then pre-procedure, there was significant gradient between the left ventricle and the aorta, and after procedure, there was almost zero gradient between the left ventricle and the aorta. So post-procedure, there was zero gradient. On echo, there was no PBL, no AR, blood pressure raised to 130/70, and there was no conduction system disturbances. Post-tower recovery, in the next 6 hours, patient become off vasopressor. In 24 hours, patient extubated, EF improved from 20 to 40%. And on day 3, patient shifted to room, and on day 4, discharged to home. So look at this picture. The patient who was unable to wean off for the inotropic support for 5 days, once we did open the valve, patient is off vasopressor in 6 hours and discharged to home in 4 days. So whenever we do a procedure, we need a heart team, and the heart team has to be between the cardiology, cardiac anesthesia, cardiac surgeon. And this heart team discussion is very important. So we are very proud on this, that each and every patient at Eternal Hospital, we do every patient with a heart team discussion. So whatever is the best for the patient, we decide according to the discussion. So what is the approach for these aortic stenosis patient? So first is the patient evaluation. We need to evaluate the symptoms, then we need to evaluate the diagnosis by the echocardiography, CT scan, and then we need to plan for the invasive procedures. Before going for any invasive procedure, we need to plan with the CT scan, sometimes cardiac MRI or the stress testing. And then the heart team evaluation has to be done, whether the patient is high risk for surgery or whether the patient is low risk for surgery or the intermediate risk for surgery. What is the other comorbidities, whether the patient can be planned for any other intervention. So then I'm not going to in detail about the diagnosis of severe aortic stenosis. We all know about the severe aortic stenosis, low flow, low gradient severe aortic stenosis, pseudo-severe AS, and the severe aortic stenosis. The important point is that now every patient, whether it's a low risk, intermediate risk or high risk patient, can go for a transcatheter aortic valve replacement, and we have a data about it. So let me go through what are the candidates for a transcatheter aortic valve replacement. So any patient with a less than 65 years and the life expectancy more than 20 years, surgical aortic valve replacement still is the class 1A indication. But the patient whose age is 65 to 75 years, either the surgical aortic valve replacement or the femoral transcatheter aortic valve replacement can be done, and both are the class 1A indication. If the patient age is more than 75 years, TAVR is the class 1 indication. And if the life expectancy of a patient is less than 10 years and the patient age is less than 75 years, still the TAVR can be considered as a class 1 indication. Patient of any age and high prohibitive risk for the surgical aortic valve replacement and the life expectancy of TAVR after TAVR is more than 1 year, and along with multiple comorbidities where the patient is in high or prohibitive risk, the TAVR is still the class 1A indication. So there are certain factors which influence the treatment. So suppose the patient is high surgical risk, go for a TAVR. If the patient is older age, go for a TAVR. If the patient is young age, should go for the surgical aortic valve. If the patient is having previous cardiac surgery, like a previous stenotomy or other cardiac surgery, should go for a TAVR. If the patient is severely frail, then patient should go for a TAVR. If there is active infective endocarditis, should go for a surgical aortic valve replacement. There are multiple factors where we can decide which patient should go for a TAVR and which patient should go for a surgical aortic valve replacement. Then what about the data? So initially it was decided to start with a high or prohibitive risk patient, then we gradually evolved, and then we have a data for the intermediate risk patient also. And this has shown that there's a different trials has gone, partner 1, partner 2, partner 3, and the conclusion is the TAVR was non-inferior or alternative to surgery in a patient with severe aortic stenosis at intermediate surgical risk patient. Then what about the low risk patient? So in the low risk patient, you can see the data is showing that among patients with severe symptomatic aortic stenosis, low surgical risk patient who underwent TAVR or surgical aortic valve replacement, the frequency of adverse cardiovascular events appears to be similar in the two groups at the 5 years follow-up. So who is not suitable for TAVR? So patient whose life expectancy is less than 1 year, and the patient whose risk of TAVR during the procedure is high than the risk of SAVR. Rest all patient can go for a TAVR. So whenever we decide about the TAVR versus SAVR, we need to look at the risk of surgery as well as we need to look at the risk of TAVR. And then we need to decide which is best for the patient. If the TAVR risk is less than the SAVR risk, then should go for a TAVR. But if the TAVR risk is more than the SAVR risk, then patient should go for a surgical aortic valve replacement. So you can ask when the TAVR risk is high. So TAVR risk can be decided according to the CT scan and the overall patient scenario. So what type of valve in the transcatheter aortic valve replacement? So it's basically a tissue valve which is made up of either bovine pericardium or the porcine pericardium. There are different types of valves which includes balloon expandable, self-expanding valve. There are certain FDA approved valves, certain Indian valves also there. And so the next question is, can TAVR be done in the bicuspid aortic valve? So in most of the trials, the bicuspid valve were excluded, and the bicuspid valve prevalence is most of the time is in the Southeast Asia, especially in the China and India. So bicuspid valve was excluded in the most of the trial, but yes, it can be done in Indian scenario. Almost 30 to 40% of the patient is having a bicuspid aortic valve in patient with severe aortic stenosis. So this is a 76-year female with bicuspid severe aortic stenosis who had a type 1A bicuspid aortic valve where the left and right were fused, and so it was decided to go with this patient for the transcatheter aortic valve replacement. So we did the aortogram, we did the balloon aortic valvoplasty, and then we did the valve positioning and the valve deployment. So then next question comes, Can it be done for the prior surgical aortic valve replacement? Yes, the patient who had a prior surgical aortic valve replacement, we can deploy a valve within the valve, which is known as a tower within the shower. So this is a new transcatheter aortic valve which is being replaced under the prior surgical aortic valve. So this is a 3 octogenarian, 82, 87, 86 year, and same day we did a 3 tower with a 3 different tower devices. So the next question is, can tower be done in a patient with severe aortic regurgitation? So it's not a class 1 indication, but being done under compassionate ground only in a patient who is high surgical risk or prohibitive risk of the patient. So this was an 81-year male with severe aortic regurgitation, multiple comorbidities, and patient was not suitable for surgical aortic valve because of the comorbidities. So we did the surgical transcatheter aortic valve replacement in this severe aortic regurgitation patient, and patient was doing perfectly fine. And this was the pre-tower echo which shows severe aortic regurgitation, and this was the post-tower echo which shows no aortic regurgitation. So this is our structural heart team, and I'm proud on this heart team because each and every procedure is not a single person job. It's a heart team which can do this procedure in a safe and effective way. Thank you.
Thank you, Dr. Prashant. And the take-home message is tower in all above the age of 65 and shower below the age of 65. And if somebody is having life expectancy is less than 1 year, then no tower. No. Thank you very much. Thank you, now I invite next speaker, Dr. Premrat Degawat, who is going to speak about the non-surgical intervention in mitral tricuspid. Question and answer can be taken later on.
So good morning, everyone. So just in few minutes, I will discuss about the non-surgical treatment of tricuspid and mitral valve, because TAVI is an established therapy, and Dr. Prashant has shown that TAVI has been done in our center various age, like highest age was 104 year that we have done at our center. So we are excellent tower center. And we are also doing the non-tower like TMVR, mitral clip, and all other surgeries. All are surgical turn-down patients we are doing with the transcatheter intervention. So, as we all know that I am going to discuss about the mitral and tricuspid. The Alan Crabier, which the photo Dr. Prashant has shown that in 2002 did the first TAVI. Before 2002, the only transcatheter treatment was the BMV. You all aware about that. It's the simple balloon mitral valvotomy. And I'm just giving you a brief review about this, that in the left side of the image, you can see the severe mitral stenosis. And simply dilating with the balloon this valve, we called balloon mitral valvotomy, BMV. And it is done on those cases which having severe mitral orifice area less than 1.5 centimeters square. And conventionally, we do it like this, that under the fluoroscopy, we cross the left atrium through the left atrial septum with the puncturing the septum. And with the annoy balloon, we can dilate this stenosis valve. So this was the only treatment which was available since last many decades. So after invention of tower, these new therapies grown up. So as you all know that surgical mitral valve repair and replacement has been associated with the excellent clinical outcome in patients with severe mitral regurgitation. But what about those patients who are surgically turned down? Because in many patients who are who have severe mitral regurgitation, still they need treatment, but surgeon has denied. So what are those patients category? Like those patients with 30 days mortality more than 10%, who have severe liver disease and renal disease, who have RV dysfunction, severe tricuspid regurgitation, severe pulmonary arterial hypertension, malignancy, and major bleeding cases. So these patients are always turned down by the surgeon. And because now these patients, we can do the transcatheter intervention in these patients without surgery, and it has shown promising result with an excellent outcome. So what are these procedures? These are the 4 procedures which we can do in the mitral valve, like mitral clip, then the Pascal system, TMVR, in-valve. TMVR means transcatheter mitral valve replacement, in-valve, in-ring, or in mitral annular calcifications. So I will discuss one by one so that you can be aware that what are these procedures and what are the mechanism of these procedures, how these are done without surgery. So first we'll discuss the mitral clip. You can see in the first image, left side, the normal anatomy. And what do you mean by normal anatomy? That if a patient with mitral regurgitation, there will be prolapsing of one of the leaflet into the LA. In the right side, you can see that the anterolateral leaflets prolapse into the LA, and this causes the mitral regurgitation. If the surgically patient with high risk, we can treat it with the mitral clip. So these are the clips. You can see the metal clips. We are fabricated metal clip, and this is the delivering device. So these clips, how these clips helps to treat the mitral regurgitation, you can see in the second image that this leaflet is prolapsing in the left atrium, and by this mitral clip, it attach these leaflet at the same level. So this is the basic mechanism of the mitral clip. And the good thing is that this procedure is very safe and effective and promising. So how it looks like that the prolapsing leaflet we attach with the clip, and the result is that regurgitation improves. And these patients have a very good prognosis. So who are the candidate of the mitral regurgitation? So simply I am saying that severe mitral regurgitation who are symptomatic, who are surgically turned down, or very high risk for surgery, this is a class 2 indication for the primary as well as the secondary mitral regurgitation. So it is very effective and safe therapy, which cases we are doing at the Eternal Hospital regularly. So this is the case of 78-year severe secondary mitral regurgitation with the ejection fraction 35% and NYHA class 3 or 4. And you can see in the first video that in the simple procedure, we just puncture the left interatrial septum, goes with the balloon dilation of the septum, goes in the left atrium, and from the left atrium, we just put a simple clip at the level of the prolapse. So you can see in this type of pre-clip, there's a severe mitral regurgitation. This is a TEE image, esophageal. This is regurgitation. And after putting this clip in this patient, you can see there was a drastic improvement in regurgitation. So this is 1 or 2 hour procedure, very safe procedure, can be done without any complication. The complication rate are also very low in this case. So those cases who are very sick and still having regurgitation, need treatment, this is the answer for that. So this is the mitral clip, but there is always a limitation with the mitral clip. So sometime, if the anatomy is not suitable, what do you mean by not suitable anatomy? If the leaflet is thickened, means that it cannot be grasped in the mitral clip, or there is a severe calcification of the leaflets, or the posterior leaflet is very short, immobile. In that case, we cannot do the mitral clip. It is the limitation of this clip, because this clip is not for everyone. At that time, we can replace this valve with the transcatheter system, which we called TMVR. This is transcatheter mitral valve replacement. And it is a very promising result and very effective and safe procedure. So this is a case of 72-year female with a degenerated surgical perimount bioprosthetic. So what we say is a valve in valve. So basically, we cannot replace the mitral valve without a valve, or means that we cannot put in the native valve. Now the transcatheter treatment of mitral valve is emerging. A new valve is coming, but is not FDA approved. We have some anchor point at the mitral leaflet. Means if there is any previous bioprosthetic valve in the mitral clip, in the mitral region, we can replace it with the new TMVR valve. Or if there is any calcification, we'll discuss in later on. So this is a case of valve in valve. Means there was a previous 10-year back perimount bioprosthetic valve, and it was degenerated because bioprosthetic valve degenerate in 8 to 10 years. The indications are same for TMVR. That indication is for the aortic stenosis, that the patient should survive more than less than 10 years, or if it is the problem that patient survive more than 20 years, then surgical treatment is the only option for that. So after puncturing the left atrium balloon dilation, we put this SAPIEN 3 in the previous mitral valve, and you can see the immediate result. The beauty of this valve transcatheter treatment is that there is on-table hemodynamic improvement, and the patient can be discharged within the 3 days without any open heart surgery. So this is we call TMVR in valve. Next is, one second. Yeah, what is TMVR in rings? So sometime by the surgery, the valve is not replaced, it's only reconstructed by the mitral annuloplasty. So these are the rings which can be surgically applied on the valve so that the mitral regurgitation improves. But after some time, when there is mitral regurgitation, then we will have to replace this valve with the transcatheter treatment. So this is the case which we have done, that in the ring we have deployed this SAPIEN valve at the mitral ring, and this we call TMVR in the ring. And you can see the result. You can see the ring and a valve, transcatheter valve. This is SAPIEN valve in the left mitral valve. Next is what is TMVR in MAC. MAC means mitral annular calcification, which I have told that without any calcification, without the anchor point, we cannot deploy the mitral, these new valve at the mitral apparatus. So what is MAC? You can see. So this is the mitral apparatus, and the white is the calcification. At least there should be severe calcification to hold the valve. So this is mitral annular calcification. Now if there is a severe calcification, means that is a rigid point at the mitral valve, then we can deploy the valve. So we have done this case. So you can see this patient was having the double valve replacement, aortic valve tower was done, then the second time at the same level, you can see this is the calcification of the mitral annulus. And at this calcification, we have deployed the SAPIEN 26, and you can see the results. So 3 things we can do at the mitral level: valve in valve, at the valve in ring, and at the mitral annular calcification. So now some brief review about the tricuspid valve, because the tricuspid valve was the forgotten valve. Why tricuspid valve to be treated? Just want to show this slide. So initially, what is the misconception, or you can say that teaching that isolated tricuspid regurgitation mainly due to the left heart system, or it is our misconception that if we improve the left heart system, the tricuspid regurgitation will improve. But you can see these studies which have shown that if there is severe tricuspid regurgitation, the CVTR has a significant impact on the survival. So the tricuspid valve should also be treated. So just brief you about how these tricuspid regurgitation patient presents, like jugular vein congestion, dyspnea, peripheral edema, renal failure. These all the sign of the right side of heart failure. So this is a case of 76-year male patient with the prior aortic, mitral, and tricuspid valve stabilization. All 3 valves has been replaced previously by the surgery, and now presented to us with the right side of heart failure symptom despite on all medication treatment. And echo shows the degenerated bioprosthetic tricuspid valve. This patient was surgically turned down because already 3 valve has been replaced. And you can see in this video that this is the aortic valve, this is the mitral valve, and this is the tricuspid valve. All two other valves are metallic valve. The tricuspid valve was the bioprosthetic, and we have to put a new valve in this tricuspid valve, which we say is the TTVR, because you have understand about TAVI. They are TMVR, TTVR, CAVI. I will show what is CAVI. So this is TTVR. We have done this patient in the tricuspid valve, and there was significant improvement after replacement of valve in the tricuspid, and the significant improvement in the right side of heart failure. And second one is what is CAVI? Because it's a new therapy which is being grown in those patients of tricuspid regurgitation or said heart failure, where we cannot put the tricuspid valve replacement. Means the patient is not suitable for tricuspid valve therapy. Then we put orthotropic valve replacement at the level of the SVC and at the level of IVC, which we say is a CAVI, caval valve implantation. So this is being new therapy which is being grown on the symptomatic RV failure patients. So how we do this? Just putting a superior SVC valve first, then we have to check the flow, then we have to put the second valve in the IVC. So what is the basic mechanism of this CAVI? That the main effect of the tricuspid regurgitation and RV dysfunction is that the backflow which comes into the IVC or hepatic vein, then into the SVC. So this two valve in the vena cava system prevents this backflow and deteriorated effect. So after implanting this, patient improve symptomatically and hemodynamically. So these are all cases which are being done, and this is also growing therapy and promising therapy in all end-stage tricuspid regurgitation who have been denied by surgeon, denied by the transcatheter treatment. And now the dedicated TriClip has also been an established treatment of the tricuspid regurgitation like MitraClip. So this is being done in new cases of all cases of tricuspid regurgitation where the valve replacement is not possible. So in conclusion is that transcatheter mitral and tricuspid valve intervention are promising, less invasive therapy, especially for surgically high-risk patients. And this is a field of innovation, is growing and promising outcome. The main thing is that proper patient selection is very important, because I have said that every patient is not for every valve. We have to select an ideal patient because it all depends on the valve anatomy, the pathophysiology, the mechanism of the valve failure. So it's very important. Imaging, planning is very important. And the last thing is that in 2024, the tricuspid valve is no longer a forgotten valve. And thank you from my side. Any question we can take?
Thank you very much for nice presentation by both Prashant as well as Prem Ratan.
Yes, sir.
From physician's point of view, 2 points are very important. Pre-intervention, that is the proper diagnosis at our peripheral level, and post-intervention, that is how to make the follow-up and follow the guidelines sent by the higher centers. I would like from both of you that please enlighten our physicians how to make the follow-up of these cases, because most of the time they are unable to come to higher centers and we have to follow in the field. Pre-intervention, it is very important for the physicians that right time diagnosis is being done, and communication to the patient, because patient have faith in his primary physician. So communication should be done in the form that communication gives meaning and purpose of referring the case to higher center. So please enlighten on these 2 points. Thank you very much.
So, Prashant, you want to ask? Yes.
So, from the pre-intervention point of view, whenever a patient is having any patient who is coming with breathlessness, we all know that we need to rule out why the patient is having a breathlessness. So we need to rule out the lung issues and we need to rule out the cardiac issues. And if the patient the most important part is to put the stethoscope on the patient's chest, because most of the time, even the cardiologist is now not putting the stethoscope on the chest of the patient, and they sometimes miss the aortic stenosis. Sometimes patient went for an angioplasty or a bypass surgery and nobody has put the stethoscope on the patient's chest. So that's why the diagnosis is important. If the patient is having aortic stenosis and if the patient is having a severe symptomatic aortic stenosis, symptoms means either in the form of angina, in the form of dyspnea, or in the form of syncope or pre-syncope, which has to be exertional. And we need to also rule out the other comorbidities which can also lead to dyspnea. Sometimes the situation is conflicting whether the patient is having a severe aortic stenosis or a moderate aortic stenosis. In those situations, we need to rule out with other tests like a dobutamine stress echo, especially in the patient with a low ejection fraction patients. And sometimes we need to do the cardiac CT scan evaluation to look at the CT calcium score. If the CT calcium score is more than 2000, especially in the men, then it's considered as a significant aortic stenosis. If it's more than 1200 in the female, then it is considered as a severe aortic stenosis, even if the gradients are low. Then comes to the, one is dobutamine stress echo, one is the cardiac CT scan. Then we need to do the proper planning. So for the proper planning, we need to do the cardiac CT scan. That is the CT aortogram scan, which includes the CT scan of the heart as well as the CT scan of the aorta as well as the femoral arteries, to look at whether the transcatheter aortic wall replacement is feasible or not. Before this, we need to look for the risk of the patient for surgical aortic wall and risk of the patient for the transcatheter aortic wall. Whether the patient is risk for the surgery is low, then straightforward we should refer the patient for the surgery. Especially in the younger patient, less than 65 years, less than 60 years patient should go for a surgery. But if the patient risk is high because of the other comorbidities, like if the patient is having a COPD, interstitial lung disease, or a patient is having a hepatic cirrhosis, hepatocellular carcinoma, or a kidney disease, CKD, where the patient, or a prior metastatic cancer or any cancer, then the patient is at high risk for surgery. In those situations, even if the age is less than 60 years, patient should go for a transcatheter aortic wall replacement. From the post-operative point of view, for the follow-up perspective, the patient has to be on a dual antiplatelet, aspirin and clopidogrel for at least 3 to 6 months, and after that only single antiplatelet is sufficient. If the patient is of advanced age, like a 90 years plus age, then even a single antiplatelet is sufficient for those patients, because we need to look at the risk-benefit ratio. And third thing is, especially if we are putting a very small valve, because in the Indian scenario, especially the female patient, their height is low, so in those patients, the size of the valve is also low, is small. So if the valve size is 20, 21.5 or 23, in those patients, we usually consider to keep the patient for 3 to 6 months for oral anticoagulant, just like in a surgical aortic valve replacement. But if the valve size is more than 23, then no need for any oral anticoagulant. So more than after 6 months, only single antiplatelet is sufficient. And for the echocardiography point of view, for the follow-up, we usually do the echo at 1 month, 6 months, and then 1 year. So every 6 months, we usually has to do the echo to know is there any point where the tower wall has started degeneration, or is there any emergence of new aortic regurgitation or a paravalvular leak, or is there anything else is now coming up. So we need to do the echo every 6 months.
So one more thing, just Dr. Prashant has explained everything, but you have asked that how, because most of the tower and TMVR patients are more in touch with the family physicians, not with the cardiologist, because you see them very regularly. We ask them to come 3 monthly, 6 monthly, and yearly. But one thing is that I want to add on this, that the symptom is very important. Any change in the symptom of that catheter, transcatheter valve placement patient, you have to be alert, because you are seeing them regularly. Any symptom in, like the grade of the symptom start from NYHA to change into NYHA 2 or 3, then you have to go for the echo of that patient immediately without wasting time, because at that time, it could be that there would be a restricted leaflet motion, thrombus on the valve, or there would be a paravalvular regurgitation, new onset of endocarditis, everything. So you have to watch the symptoms. And regular echo, if you think that the symptom has changed, you have to go for the echo immediately. And if the transthoracic echo is not sufficient, you think that still the symptom is due to the valve replacement or valve problem, then you have to go for the transesophageal echocardiography. That is very important in the physician perspective, because that you see the symptom at the first time. then you refer the patient to the cardiologist. So it's very important.
Yeah, Prashant,
so I think
just update about minimalistic tower. These days we mobilize very early and we discharge very next day. Everywhere, in Europe and all America also.
So the term minimalistic tower is basically coined because we want to minimize the infection. We want to minimize the cut on the patient's body. So what we do in the minimalistic tower is, previously when the tower was started, it was of almost 20 to 24 French system, but now the tower can be done even with a 14 French system. So the size of the sheath has been come down, and we can do the tower within a 45 minutes to 1 hour without any open heart surgery, without any general anesthesia. Previously it has to be under GA, but now we do it under conscious sedation. So most of the time we do it under conscious sedation, where the patient is just sleeping. We can ask the patient to, he can wake up at any moment. Second thing, we do the intervention with a minimal cut on the body, a minimal puncture on the body. Third thing, immediately after the procedure, we shift the patient to ICU, and after 3 to 4 hours, patient can sit, he can start eating, and after 24 hours, patient can walk. And after 24 to 48 hours, patient can go home. In US, we usually discharge the patient after 24 hours, post-hour, but here in India, we usually keep the patient for 2 to 3 days just for the antibiotic perspective, because sometimes the infection rate in Indian perspective is relatively high compared to the US.
So I think the whole role is the physicians. No? Nowadays, there is a patient inertia and the physician inertia. As Dr. Prashant started with the case that at the age of 75, somebody comes with an NYHF 4. So I think this is a big problem in India. Why a patient land up in the NYHF 4 and he diagnosed at the age of 75 with the critical AS? So if the guideline says that after the 60 or 60-65, we can go with the preventive cardiology examination of each and every patient, then we could have diagnosed earlier as a mild AS, then moderate, and then we can early go for the intervention. So I think, thank you very much, both the speakers.
Yeah, there are a number of cases in follow-up with the physician. The patient has been diagnosed severe AS, LV function is normal, he's a class 2. The patient is not willing for any intervention, so they continue on medical follow-up. Rather than continue with a medical follow-up, they should try to convince them.
Yeah,
in 6 months down the line, he might be in a class 3, class 4, and with LV dysfunction, he becomes very high risk.
That's why I said there is a physician inertia also. There is a physician inertia also. Nobody want to, the bad word, nobody want to lose his patient, and that is a big problem with us. And we should see that we have to send as early as possible to the intervention cardiologist for the intervention, if she or he needs an intervention. I have seen just 3 days back one patient who have seen 3-4 respiratory physicians, and everybody was giving him an inhaler. Or somebody was giving in a DPI or MDI, and patient, they said that it's asthma. Then she came to me, the age 65 years, and then she was in the CHF. So simple, nobody did that, the echo. So that is the reason we have to go for the investigations timely, and we should refer patient to the higher center for the interventions. Any more questions?
It's not only always from the physician's perspective, it's sometimes from the patient perspective also, because patient sometimes lives in a denial mode. They don't want to accept that they have a severe aortic stenosis, and sometimes they limit their activities. And so they said that we are not having any symptoms, but they are not having any symptoms because they have limited their activities. So, because I had one patient who was 61-year-old, patient has a severe aortic stenosis, bicuspid aortic wall. I saw that patient, and I asked that patient to go for a surgical aortic wall replacement because you are too young for this, for the transcatheter aortic wall replacement, as well as you are low risk for surgical aortic wall replacement. But patient was not convinced for the surgery at all. He just wanted to go for a transcatheter aortic wall replacement. But I emphasized that you should go for a surgical aortic wall replacement. He didn't go anywhere. He was just living at home. For after 6 months, he came up again in an acute heart failure situation. At the initial first time contact, his ejection fraction was 60%, and when he landed up again, he was in 20% of ejection fraction. At that point of time, he was in the low risk for surgery, but now he becomes a high risk for surgery. Despite bicuspid aortic wall, now the congestive heart failure, low ejection fraction, 20% of VF, now he becomes the high risk for surgery. We discussed in a heart team evaluation, and then we decided to go for a transcatheter aortic valve replacement, but that time the tower is also the high risk for that patient. But the patient went well, but the question is sometimes the patient's also in a denial mode. So patient went well, patient ejection fraction improved from 20 to 45%. Now he is walking almost 4 to 5 kilometers daily without any discomfort. Yeah. No, but if he had done it in a 6 month before, the surgical aortic valve replacement would be better for him, not the transcatheter aortic valve. Because if we look at the long-term outcome, because after 10 years, we would have to do another tower and tower. But so the tower and tower is relatively not easy compared to the shower and tower. So if that patient has gone for a surgical aortic valve replacement at the age of 61 years, and then at the age of 71 years, I am doing a tower in shower. So that would be relatively better option for the patient. But tower and tower at the age of 71 years would be relatively difficult for the patient.
Thank you very much. Before we conclude this session, any question from audience, please?
If there is any technology in new era, as we know the AI is developing, watch the progression of structural heart disease, anything there. And I am not aware much about it. Is there?
So you just want,
artificial intelligence
in terms
can help
of
anyone to watch the progression of his anything. Just
so if yes, but
as
it
in arrhythmias, there are watch by watch. And
so
anything to watch structural
best watch is the symptoms. Still, we are not aware that any app or any AI is involved in, but
if patient is not educated enough to know the importance of his early sign and symptoms and recognizing them. As we know in heart failure, it is spiral, downward spiral. Especially getting symptoms, he limited his activity. And that's how many patients of heart failure is not diagnosed until unless they are challenged in some game field or somewhere else. Sportsmen identify these things early. They are try to perform at higher level and then they are not able to perform that same activity as now. Patient is not educated enough, and as we know, everyone is not educated enough to address himself properly. Then any technology can help for any future prospect of it.
Still we are
So AI is still in the nascent phase. Artificial intelligence is still in the nascent phase, and we all are still evolving. And the studies are ongoing, but we still don't know. As of now, there is no proper documented study or no proper documented tool to diagnose these patients early, even if the patient is not having any symptoms.
I think it will not happen. It is very difficult to diagnose these patients by AI in the clinical. It's very difficult because even the clinicians can miss the diagnosis. So how can an AI can diagnose? But how a clinician diagnose with the echocardiography? So I think it could not be possible to be diagnosed by the AI, but it's not possible.
Right now.
And second thing, about the aortic stenosis or any valve disease, it's unpredictable. Not every 90-year-old patient develops severe aortic stenosis, and not every 90-year patient get a mitral regurgitation. Many of the patients, and not every bicuspid aortic valve patient develops severe aortic stenosis. So nobody can predict which patient will develop severe aortic stenosis, but yes, the follow-up is essential. Once the patient has started developing aortic sclerosis, if there is a mild AS, then the follow-up echo has to be relatively early, like a 6 month or every 3 months, 6 months or 1 year follow, so that we can diagnose the patient's severe aortic stenosis as early as possible. So far, the echo is the only tool to diagnose the aortic stenosis.
So thank you very much. We conclude this session.
Thank you very much, Dr. Prashant and Dr. Premratan Degawat. Now, we are headed to the last session of this 2 days medicine update conference, which is Cardiology Intervention Symposium. I would request Dr. A.S. Rathore sir, Dr. Ranka sir, Dr. V.K. Jain sir, please stay back to your chair. And I would request Dr. Suresh Mildatwal sir and Dr. Marun Mathur sir kindly join us on stage. And as our first speaker of Intervention Symposium is Dr. Sanjeev K. Sharma, and his topic is role of interventional imaging in coronary interventions, what physicians need to know. So I would like to invite Dr. Sanjeev K. Sharma on the dais to present his session. Sir, please.
Yeah, good morning, everyone. And we had a wonderful last 1.5 day conference. And moving to other, it was a wonderful session, structural heart disease, because it's growing at a fast pace and all the physicians need to be updated about what's going on in structural heart space. And we had a very nice presentation by Dr. Prashant and also Dr. Payne. Now, moving on to the coronary symposium. These days, more and more cases with the complex coronary artery disease are being taken up for the intervention, then going for the CABG because of multiple reasons, because of advanced age, multiple comorbid conditions. Patient is not suitable for the bypass surgery. Earlier, there used to be like medical follow-up or medical therapy. But now, the more and more complex cases are being done with the help of advanced imaging techniques and then plaque modification technique with the rotablation, orbital atherectomy, and the IVL, and also with a patient with a severe LV dysfunction with the help of LV support like Ampella and at times the ECMO if the patient cannot afford it. So how does it make a difference, rule of intravascular imaging? Imaging is being done very frequently now. In our hospitals, more than 60% of cases are being done with the imaging guidance, and imaging can be done with the two different modality. One is intravascular ultrasound. Like the sonography or ultrasound we do for abdomen, it's a catheter which we advance over the wire and that scans the vessel from inside and give us an idea about the plaque morphology and what best plaque modification strategy we should use for the bed preparation, and so that stent can be deployed. The best outcome for the PCR or angioplasty depends on how best we have deployed the stent. And both the edges, proximal distal edges are in the healthy zone, and also the expansion of stent should not be compromised because of calcium or some other thing. So imaging helps in optimizing the stent deployment. And apart from IVUS, second modality is the optical coherence tomography, and that is just like an infrared camera inside your vessel. Over the wire, we advance the catheter, and we flush the dye, and that imaging scanning camera scans the vessel from inside in a span of few seconds, and we get absolute clarity from the inside. This is like 360-degree your visualization of the vessel rather than biplane, what we do with the angiography. Injecting dye is the biplane, two orthogonal plane, but the imaging. So why intravascular imaging? This is what you see, and this is what is there. So it's a reflection. We are seeing the radiographic images is being reflected, and it's been taken by the image intensifier, and then it's being reflected. It's not always true. It's a biplane, but the reality is different. That is only possible by the three-dimensional imaging, and this is what we see at a normal, nearly normal lesion can have a eccentric calcified lesion. So it's very important to use imaging whenever it's required, based on the cardiologist's discretion for the optimizing the intervention result. This is just like looking into the vessel. Intravascular imaging means you are going inside the vessel and seeing the vessel in the real-time view, just putting in a camera and seeing. So it was just like eyeballing for the routine angiography-based intervention. Now we can clearly see the vessel size, the lesion length, and also the lesion morphology to decide the best plaque modification strategy. This is what we were talking about, the biplane angiographic images. And the imaging gives us 360-degree tomographical image by both IVUS and the OCT. This is how it helps in minimizing the immediate complications. Like in a right panel, you can see the under-expanded stent. There is a middle, you can see the dog boning. Stent is not being expanded because of heavy calcium. It's not allowing stent to get expanded fully. And that is a recipe for the immediate complication. If you leave it like this, patient can come back with the stent thrombosis and the acute MI in the near future. And the second, left panel is the dissection, because we have not been able to see the lesion or plaque morphology, and there's a dissection, although it can be tabled on the table, but in the underexpanded stent, we need to do something. Like late consequence of underdeployed stent is the restenosis. If the stent is not being deployed, you can have a restenosis in a short term, 3 to 6 months time, and also the stent thrombosis in the late future. Even late thrombosis is also very common. And this is how these images, OCT images, looks like. We can see the struts hanging in this panel, and it's not being opposed to the vessel wall. So this is a clear recipe for the stent thrombosis if you don't expand it fully. So imaging helps in optimizing the angioplasty result. These are the few things which we do as a pre-PCI. Like pre-PCI means before the angioplasty, before the balloon dilatation of stent. How we do it? We define the lesion morphology. In acute coronary syndrome, we have a lipid-rich plaque with a thin cap, and we can have a plaque erosion or plaque rupture. So why to differentiate between the plaque erosion and rupture? If there's an erosion with thrombus and borderline lesion, we can keep on antithrombotics, need not to stent it. But if there's a plaque rupture with the intimal disruption, there is high chance of thrombosis again. So you have to put a stent. So it's necessary to differentiate between plaque erosion and rupture, especially in the ACS setting. In a stable CAD, we need to see whether the lesion is fibrotic or fibrocalcific. At times, lesion looks like a 80% lesion, and calcium is not visible on angiogram. And when we do the imaging, there is a heavy calcium or the calcified nodule also. So it's very important to have an idea about the stable CAD patients. In calcific lesion, we see the thickness of the calcium, length of the calcium, and the arc of calcium, whether it's a 180, 270, or the 360-degree arc of calcium, and what best modality we can use. We can have a calcium nodule also, which needs a special treatment with a rotational atherectomy followed by IVL if required. And we get a clarity about the lesion length, healthy to healthy area, and about the vessel diameter so that we can have a proper selection of the stent size. For the post-PCI, after deploying stent, what we see is the medial dissection, whether there is an edge dissection of the both edges or stent apposition and expansion. These are the three important. This we say is an OCT or MLD max criteria as an OCT algorithm. MLD is for morphology, lesion, and diameter. This is a pre-PCI, just to have a strategy for the PCI. And after deployment of stent, we optimize by seeing the medial dissection, apposition, and the stent expansion. Left side is a IVUS image, intravascular ultrasound. Right side is a OCT image. We can clearly see on the left side there is a calcium sheet right from the 7 o'clock to the 1 o'clock. There is a calcium sheet and there is an echo drop. On the right side there is we can see the calcium in your OCT images very clearly, and which really helps in making us know what to use for the pre-dilatation or plaque modification like rotation. It's a fibrotic plaque which is nearly uniform. The few examples, 6 or 7 examples, I'll go a little quick. First case is a ACS with plaque erosion. Young patient, 48 years old, came with the ACS, EF 45-50%, LAD territory is hypokinetic, stable hemodynamics. And his angiogram, post-reconstruction, shows a borderline lesion, like 60%, 50-60% lesion. And on intravascular imaging, we could see the plaque erosion with the thrombus. You can see on the right side from 11 o'clock till 7 o'clock, there is a thrombus with erosion. There is no disruption of intima, or there is no your plaque rupture. So, and the size was 4 millimeter square everywhere. So it was not a very critical lesion. It was a borderline lesion with a plaque erosion and some thrombus. So this patient was kept on antithrombotics, enoxaparin twice a day for 5 days, and antiplatelets, and he's doing well on the follow-up. So borderline lesion with plaque erosion can be kept on medical follow-up. Had it been a plaque rupture, we would have stented it. And second case is again young, 44 years old, infeolami, presented to us, and angiogram shows 50-60% lesion in the LAD, and also right side is or close to 60% lesion, 60-70% lesion. And he underwent this OCT pullback, and OCT pullback clearly shows. In the second panel, you can see there's an intimal flap. There's a clear dissection on the second or third panel. And on the basis of that, and the size is also 3.81, and intimal flap is clearly visible. There's a disruption of intima. So whenever there's a disruption of intima or the plaque rupture, you should stent this. Otherwise, if you leave it, there are high chances of rethrombotic event, and patient come back with a recurrent MI. So this patient was stented, dilated, and then put in stent. And post-stent, we had a wonderful result and clear expansion. You can see in this image, stent rendered view. These are the struts which are clearly visible. The whole circumference is very well deployed, very well expanded stent. This is the final result. Now coming to at the same time we did a FFR for the LAD because LAD is considered to be the major vessel supplying the 60% of heart. So whenever there's a borderline lesion in LAD, we should do a physiological assessment. So FFR is more than 0.80, is a 0.85. That means a physiologically insignificant lesion in the LAD and you leave it. This is a state-of-art practice which is being done in our hospital. All the interventionists are doing a wonderful job. And the third case is a plaque modification based on the OCT. 64 years old patient with a dyslipidemia came with the ACS, unstable angina, ejection fraction normal. And this is the angiographic picture. On the right panel, you can see in the cranial view, this is a long segment, 80 to 90% calcified lesion, but it's not very easily visible on the angiography, although we can see the fluoroscopic image. When there is a heavy calcium, we can see a tram track-like calcification on angiographic picture. And in borderline cases, we are not able to see calcium clearly. So here, the size of the vessel, minimal area is less than 4, is 2.24, 2.98, and we can see on the second and third panel, it's like 180-degree arc of calcium is visible, and on the fourth panel, we can see the calcium nodule, which is protruding inside the lumen. So it gives a clarity about how much is the calcium, how long is the arc of calcium, whether it is a calcium nodule. Accordingly, we can decide which plaque modification strategy we should use. So based on this, it uses IVL. This is 3.5 millimeter intravascular lithotripsy balloon. Also says shockwave balloon. And 80 pulses were given along the whole length of the calcified long proximal to mid-LAD region. And subsequently, we can see the crack. IVL is a definite crack in the calcium, and which is being depicted by all these arrows. After IVL, then there's dilatation with a non-compliant balloon to prepare the bed adequately. Then subsequently, the stent 3.5, 48, and 415 were deployed overlapping 2 stents. And then we can see the post-dilatation, and subsequently, this is intravascular imaging, and a very well deployed stent. So if the stent is well expanded after taking care of the calcium by either IVL or the rotablation, the stent expansion is quite good. So long-term outcome is excellent. So all the complex cases are being taken care with the use of imaging. So this is a very well expanded. You can see there hardly there is any under expansion from the proximal to mid-LAD, and these patients are doing good. Fourth case is a calcium modification with rotablation based on the IVUS imaging. The patient is a diabetic, hypertensive, 72 years old male with a close to normal LV function, had 2-vessel disease. LAD has a tortuous calcium in the proximal to mid segment, and there is IVUS imaging. IVUS imaging is literally black and white picture, like we used to do a black and white television in our earlier days of 70s, late 70s and 80s. And OCT gives us a clear, bright picture, which is more fascinating to the eyes, but it still gives a good idea. And there are some instances where we prefer IVUS, like a high creatinine value, so that we can't use a dye because OCT needs a dye clearance and blood clearance by the injecting dye. But in IVUS, you don't use any dye. And second is when the vessel size is bigger and also left-hand bifurcation, we prefer IVUS over the OCT. So after having an idea about the calcium, it was 1.75 Burr rotablation. Rotablation Burr comes in 1.25, 1.5, 1.75 and 2 millimeter also. It's a large vessel, so 1.75 Burr is being used. And this is after rotablation, then the pre-dilatation with the NC balloon, preparing the bed, and subsequently stent is being deployed. And the result is quite good. There's a good expansion of the stent throughout the night. You can see the LAD, and subsequently the circumflex was taken care. The next is IVL under IVUS guidance, 57 years old, anti-OLMI, EF 35-40%, stable hemodynamics. In this case, there was IVUS run of the LAD. There was a calcium, 270-degree arc of calcium, and at places it was 360-degree and taken care by the intravascular lithotripsy or the IVL balloon. You can see the clear cracks in the calcium. So IVL is a wonderful tool when the vessel size is bigger and there is a 360 or more than 270-degree arc of calcium. And subsequently stent was deployed and the result was excellent. 2 overlapping stents. And going to the next case. And the dissection, this is very important. When we do a PCI, we can have some kind of a complications which is not visible to your eye or by the angiographic picture. So this case was planned for the PCI, EF 40%, LAD PCI was done, but at the end of the procedure, on the IVUS pullback, we could see I'll show you the dissection flap, And after the finishing the LED PCI, on the final IVUS run, I'll show you. You can see the top panel, there's a clear dissection in the left main. It could be because of guiding catheter or because of one of the hardware, and that was left main to LED, one more stent was used. So imaging also helps in detecting some complications which are very rare, but often missed by our usual angiography picture. So this patient came from the South India, and then we had to give the best result, and second stent was deployed overlapping with the previous one, and this was the final result was good. So last case is a complex left main bifurcation with imaging guidance. Whenever you talk about the left mains, we should always do the imaging. Left main bifurcation PCI should not be done without imaging guidance, because it's very important to deploy the stent in such a discrepancy in the LED and left main, or also in the circumflex. We have to see the carina also. So 86-year-old diabetic hypertensive patient, CKD, is a patient with a ACS, recurrent LVF, poor ejection fraction. This case was done with a LV support with the Ampella. And you can see the heavily calcified distal left main with the LED circumflex proximal bad calcium. And initially rota was done with 1.5 bar so that we can make some space for the IVL balloon to go. And after rotablation of the LED and circumflex in the left main, then IVL 3.5 millimeter balloon was used. And all the 80 pulses were given from the LED to left main and circumflex to left main. And subsequently 2 stents in the bifurcation stenting, mini crush, were deployed in the left main, and eventual outcome was excellent. And which we confirmed by the IVUS images. You can see this point of confluence, the figure of 8, and the well-deployed stent in the LED as well as in the left main and also in the circumflex. This patient is doing well on the follow-up. And this is one of the study which was published last year, Renovate Complex PCI. So it's a prospective multi-center randomized trial, 20 sites of Korea. We can clearly see the imaging-guided PCI is a significantly less number of events over 3 years as compared to the angiographic-guided PCI. So the bottom line is, whenever we have a complex lesion like bad calcium, left main bifurcation, or the ACS-like situation, we should use imaging often so that we can give the best result to the patient. So take-home message is, coronary imaging improves the outcome for the all complex and high-risk left main bifurcation PCI or any other bifurcation PCI, and also the bad calcium and also ACS with ambiguous borderline lesion, so that we can decide whether to stent it or not. And coronary imaging also helps in detection and the management of the PCI complication, and which helps in giving the best outcome, short as well as long term. Thank you very much.
Thank you very much, Dr. Sanjeev, who is well-established, renowned faculty on cardiology in the town and even in the region. He has very well explained that how the intravascular, intervention and assessment helps and optimizing the PCI. Am I correct?
Yes. Yes.
So he has well established that how pre-PCI, post-PCI, if intravascular ultrasound is being done and you are able to know the size of the lumen, the culprit plaque, the walls, as well as the depth of the lesion even. Definitely, we will definitely like to have some question, if they are arising out of this presentation in your mind, regarding intravascular assessment of the vessels before PCI and post-PCI. Any question from audience?
Dr. Sanjeev, most of the time we face problem when we are referring patient for the angiography, and that the patient is saying that they are asking how much we have to spend. Normally we say that you might need 1 to 1.5 lakhs rupees. But when OCT or IVUS or these things are being indicated, rotablator, then please tell me what is the cost of the rotablation, OCT and IVUS, so that when the patient is coming to you, we can tell him that if you require OCT or the IVUS or rotablator, then this cost may be added into your bill.
So first is all the imaging procedures are being covered by all insurance companies, including RGHS. We are doing quite a good number of RGS patients, and RGS gives absolute clearance for the imaging and as well as FFR. And all other insurance company, they're also being covered. And for the cash paying patient, it's a 50,000 for OCT and IVUS. We have made a package, 50,000 flat for the IVUS and OCT. And same is for FFR. So it's not a big cost issue these days. And about the rotablation, it costs 1 lakh rupees for the economic package. And orbital atherectomy is going to come back. Now it's being launched again by the Abbott Vascular. It will be in the cost around 2.5 lakhs, 2.25, 2.5. And IVL is costing 3 lakhs rupees for a catheter, which is 80 pulses. For 120 pulses, it's close to 3.4, 3.5 lakhs. And the standard angioplasty package plus instant is 41,000 by the government of India. And the RGHS is 23,500. So angioplasty is not a big issue, and as a part of a cost, and imaging is also nominal. It's not very huge difference. For the cash paying patient, it's 50,000 for the FFR and the OCT.
Thank you very much.
Thank you. Thank you, sir.
Now I invite Dr. Milind Srivastava to talk about antiplatelets and coronary artery disease.
Dr. Srivastava, this is very important subject from the physician's perspective. What antiplatelets are to be used, when to use single, double. Always surgeon and dentist, ophthalmologist ask from us when to stop, 2 days, 3 days, 5 days or 10 days before surgery. The resistance of antiplatelets in particular situation, in particular patient, these have been the common questions when such topics are being discussed. I hope you will address all these questions from the physician's point of view.
So first of all, I would like to extend my thanks to Dr. Makkar and Dr. Kush for giving me this topic and considering me for this. And rightly said, this is a very important topic which needs to be rebrushed according to the recent guidelines in our day-to-day practice. So to start the presentation, first we should know what are the antiplatelet drugs. I think we all know about it. I just revise it. We have 3 or 4 groups of antiplatelet drugs. First is the thienopyridine. Those are the ADP receptor antagonists that include ticlopidine, clopidogrel, prasugrel. Then comes the COX inhibitor that includes aspirin. Then phosphodiesterase inhibitor that includes diaparidamol. Then comes the injectable antiplatelet drugs that is GP2B3A inhibitor, which includes tirofiban, aptifebatide, and apixaban. So these are the mechanism of action shown in this slide, that aptifebatide, tirofiban, and apixaban, they act on GP2B3A inhibitor. Clopidogrel, ticagrelor, prasugrel, cangrelor, they act on P2Y12 receptor, and aspirin acts on thromboxane receptors. So word about the aspirin. There are low-dose aspirin inhibits COX-1 receptors irreversibly and inhibit platelet generation of thromboxane A2. Bleeding events are increased with the aspirin when dose increase from 100 milligram per day. And bleeding events with aspirin are mostly of gastric origin with a frequency of around 2% per year. Loading dose of aspirin is between 150 to 300 milligram, followed by maintenance dose of 75 to 100 milligram OD in all ACS patients. And current OASIS 7 study and recent studies have shown that there is no significant difference between high dose of aspirin versus low dose of aspirin for primary outcome measures in ACS patients. So this study published in 2021 in NEJM, which concludes that effectiveness and safety outcomes did not differ significantly with daily dose of aspirin of 81 milligram when compared with 320 milligram of aspirin in a patients with established atherosclerotic cardiovascular disease. So now comes the P2Y12 inhibitor. We'll discuss 3 drugs, clopidogrel, prasugrel, and ticagrelor, which are common drugs in our day-to-day practice. And in this slide, you can see that except ticagrelor, both are prodrugs. Onset of action is faster with prasugrel and ticagrelor. Duration of action is longest with the prasugrel. And except ticagrelor, both are irreversibly inhibit the platelets. Dyspnea and ventricular pauses are more common with ticagrelor, while bleeding risk is highest with the prasugrel and lowest with clopidogrel. And prasugrel should not be used in the patients with prior history of stroke. So these are the landmark trials. I think a lot of time they have been discussed, so I'm not going into detail. So these are the loading dose and the maintenance dose. I think we all are well aware of it. One thing I would like to highlight that in patients who are weighing less than 60 kilograms of weight, maintenance dose of prasugrel should be reduced to half, and it is contraindicated in the patients with prior stroke. So now come the timing of the loading in PCI. So in STEMI patient, pre-treatment with P2Y12 receptor inhibitor may be considered. In NSTEMI patients, they have been divided into two categories. Patients who are going for early PCI, means PCI less than 24 hours, so before knowing the coronary anatomy, it is not recommended. Patients who are going for late PCI, means PCI after 24 hours, they may be considered according to their bleeding risk. All ACS patients undergoing PCI who did not receive pre-treatment or loading dose is recommended at the time of PCI. So this is Atlantic trial, which shows that pre-treatment with ticagrelor in the ambulance did not improve TIMI flow grade 3, but decreased the rate of definite stent thrombosis both within 24 and within 24 hours and 30 days. This ACOST trial, where investigator found that NSTEMI patients who were scheduled to undergo PCI within 48 hours after admission, pre-treatment with prasugrel at the time of diagnosis did not reduce the rate of major ischemic events up to the day 30, but increased the risk of major bleeding complications. So what is the optimal duration of DAPT? So now a rigid 1-year recommendation of initial DAPT duration has been revised, and optimal duration is now being defined by balancing the risk of bleeding versus avoiding future ischemic events. So for this, patient has been categorized according to their bleeding and the ischemic risk. So shorter duration of DAPT is reserved for the patients who has high bleeding risk or low ischemic risk or both, while longer duration of DAPT is reserved for the patient who has low bleeding risk or high ischemic risk or both. So what are the high ischemic risk? The patient with diabetes, main vessel disease, recurrent MI, complex CAD, who has more than 3 stents implanted during the procedure, or patient with stent thrombosis, all contribute high ischemic risk factors, while patients with malignancy, CKD, recent surgery on oral anticoagulants, stroke, cirrhosis, anemia, more than 75 years of age, or thrombocytopenia, or patient with a history of intracranial hemorrhage, comes into a high bleeding risk. So according to the ischemic and the bleeding risk, we have to do the risk stratification, which is based on the calculation of DAPT score, Paris score, precise DAPT score, or ARC bleeding score. And according to these scores and their results, we divide the patients between high ischemic risk or high bleeding risk and tailor our antiplatelet therapy according to their status. So patients with high ischemic risk should go on prolonged DAPT, prolonged P2Y12 inhibitor monotherapy, and patients with high bleeding risk should go on short DAPT, early P2Y12 inhibitor monotherapy, and they should be considered for de-escalation during the follow-up. So these are the components. Because of time constraint, I'm not going into the detail because this is a very long topic. So these are the major and the minor high bleeding risk criteria, any patients who is having more than one major criteria or more than 2 minor criteria is considered as a high bleeding risk patient. And this is how we have calculated the precise DAPT or DAPT score. So, to assessment of the ischemic risk, there are two parameters, the clinical parameters or procedural parameters. And clinical parameters includes advanced age, multiple prior MI, extensive CAD, diabetes mellitus, and CKD. While in patients' procedural factor which contribute the risk of higher stent thrombosis, that includes history of prior stent thrombosis on adequate antiplatelet therapy, stenting of the sole surviving coronary artery, diffuse main vessel disease with diabetes, at least 3 lesions treated at a time, at least 3 stents implanted during the procedure, or bifurcation stenting with 2 stents, total stent length more than 60 millimeter, or chronic total occlusion. Now comes for DAPT for stable ischemic heart disease who is undergoing PCI. So here the ESC recommendation is aspirin should be continued. Clopidogrel therapy along with aspirin is recommended for 6 months following coronary stenting irrespective of stent type unless shorter duration is indicated due to high bleeding risk. Or clopidogrel therapy along with aspirin should be reserved for 3 months in a patients with higher risk of life-threatening bleeding. Similarly, in patients who has a very high bleeding risk, clopidogrel therapy should be continued for a month. After that, it should be considered to withdraw. Prasugrel or ticagrelor may be considered at least as the initial therapy in a specific high-risk situations when patient is taken for elective stenting. Those situations are suboptimal stent deployment, higher risk of stent thrombosis, complex left main stem or multivessel stenting, or if DAPT cannot be used because of aspirin intolerance. Sometimes we get a patients who are allergic to aspirin, so remember this. You can use prasugrel and ticagrelor in such group of patients. Again, these are the trials basis on which these guidelines has been established. Now comes DAPT for the ACS. So again, aspirin is recommended in all the patients with a loading and a maintenance dose of 75 to 100 milligram OD. In all ACS patients, P2Y12 receptor inhibitor is recommended in addition to the aspirin, given an initial oral loading dose followed by a maintenance dose for 12 months unless there is high bleeding risk. This is again, there is a new addition in the guidelines that PPI combination with DAPT is recommended in a patient at high risk of gastrointestinal bleeding, and they are recommended as a class 1A recommendation. Prasugrel is recommended in a P2Y12 receptor inhibitor naive patients proceeding for PCI with a loading and maintenance dose. Again, maintenance dose should be reduced 5 milligram per day for the patient who are aging more than 75 years or weighing less than 60 kilograms. Ticagrelor is recommended irrespective of the treatment strategy, whether patient is taken for the invasive or conservative arm in a standard loading and maintenance dose. Now comes the clopidogrel, which is recommended when prasugrel or ticagrelor are not available or cannot be tolerated or contraindicated. Prasugrel should be considered in a preference to ticagrelor for an ACS patient who proceeds for PCI. So in this, they have upgraded the prasugrel over ticagrelor. GP2B3A receptor antagonist should be considered if there is evidence of no reflow or thrombotic complication during PCI. And in P2Y12 receptor inhibitor naive patients who are undergoing for PCI, cangrelor may be considered. In older ACS patients, especially if high bleeding risk is there, clopidogrel should be considered. Now comes the pre-treatment with P2Y12 receptor inhibitor may be considered in the patients who are undergoing for primary PCI, pre-treatment with P2Y12 receptor inhibitor may be considered in non-ST elevation MI who are not expected to undergo an early invasive strategy or do not have high bleeding risk, but routine pre-treatment with P2Y12 receptor inhibitor in non-ST elevation MI whom coronary anatomy is not known and early invasive strategy is not planned, it is not recommended. These are the again trials on which basis these guidelines has been established. Now comes DAPT in a special situation. So DAPT in CABG. Again, the recommendation in ACS patient treated with DAPT undergoing bypass surgery, resumption of the P2Y12 inhibitor therapy as soon as possible after surgery should be done, and it should be continued for 1 year. In CABG patients with prior MI who are at high risk of severe bleeding, we can discontinue P2Y12 inhibitor after 6 months. In patients with high ischemic risk with prior MI and CABG tolerated DAPT without bleeding complication, they have extended the continuation of DAPT duration from 1 year to 3 years. So now comes a very important question, DAPT in perioperative setting. So what guidelines says that nowadays there are a lot of surgeons who are comfortably operate on 75 milligram of aspirin. So we should continue the aspirin perioperative if bleeding risk allows and resume the recommended antiplatelet therapy post-op as soon as possible. For elective surgery, discontinue P2Y12 inhibitor after a month, irrespective of the stent type implanted, if aspirin is maintained throughout the perioperative period. And discontinuation for ticagrelor, you have to stop it for 3 days, for clopidogrel for 5 days, and for prasugrel for 7 days, you have to stop. In patients who had recent MI or other high ischemic risk factor requiring DAPT, we should postpone elective surgery for 6 months. Surgery within a month after stenting and DAPT discontinuation should be required. We should bridge it with IV antiplatelet drugs. And elective non-cardiac surgery within a month of angioplasty is not recommended. So this chart is showing the discontinuation period for the drugs required. For ticagrelor, it is 3 days. For clopidogrel, it is 5 days. And for prasugrel, it is 7 days. So now, DAPT switching guidelines. One more important question, how to switch the P2Y12 inhibitor in the different groups. Sometimes patient is on ticagrelor, we want to shift this patient of prasugrel, or vice versa. So this slide is showing the protocol. If we are switching the P2Y12 inhibitor in acute setting, means less than 1 month of the procedure, we have to reload the drug, whatever drug patient is taking, after 24 hours. Suppose if you want to shift your patient from clopidogrel to prasugrel, you have to reload the patient with prasugrel after 24 hours of last dose of clopidogrel. And same pattern should be followed between switching between clopidogrel and ticagrelor and prasugrel. But in chronic settings, sometimes you are not required to reload your patient. Suppose you are switching between clopidogrel to prasugrel. So after 24 hours, you can start maintenance dose of prasugrel without loading. If you are switching your patient from prasugrel to clopidogrel, after 24 hours of last dose of prasugrel, you can straight away start with maintenance dose of clopidogrel, that is 75 milligram. Now comes the switching between clopidogrel and ticagrelor. If you are switching your patient from clopidogrel to ticagrelor, you need not to load the patient with ticagrelor. After 24 hours of last dose of clopidogrel, you can start with the maintenance dose of ticagrelor, that is 90 milligram BD. But if you are switching your patient from ticagrelor to clopidogrel, you need to reload after 24 hours of last dose of ticagrelor with clopidogrel, and then you can continue with the maintenance therapy. Now comes the switching between prasugrel and ticagrelor. Suppose if you want to switching your patient from prasugrel to ticagrelor, after 24 hours of the last dose of prasugrel, you can straight away continue with the maintenance dose of ticagrelor. But if you are switching your patient from ticagrelor to prasugrel, you have to reload. So take-home message is, DAPT use is like a double-edged sword. We have to use it very carefully. It offers the benefit of ischemic protection, and on other hand, it also increases the bleeding risk. Risk score can help to tailor the duration of DAPT based on the patient needs. And when considering the choice of antiplatelet regime for the treatment of ACS who are undergoing PCI, we need to weigh the risk versus benefit for intensive inhibition of the platelet aggregation. Thank you.
Sir, thank you very much. Now session is open for the discussion. Anybody who wants to ask the questions, most welcome. So no one. So we conclude this session. Thank you very much, sir.
Thank you.
So thank you very much, Dr. Sanjeev K. Sharma, Dr. Milind Srivastava, and the elite panel. Thank you very much for your precious time. And one thing I would like to say that you were such a nice audience throughout since last 1.5 days. And I would now invite Dr. Kush Kumar Bhagat, our organizing secretary, for valedictory and vote of thanks. Sir, please.
So we had a wonderful session, and as we come to the close of the Medicine Update 2024, so I would like to express my sincere thanks to all the esteemed faculty, all the delegates who have, who took time from their busy schedule, who came from all across Rajasthan and attended our meeting, gave their valuable insights. From Ajmer, we had guests from Ajmer, Sikar, Pali, everywhere, Ganganagar. I would like to thank them with the bottom of my heart. I would also like to thank the senior physicians, especially from Jaipur also. They came from their busy schedule on Sunday morning and gave their valuable insights. Secondly, it wouldn't have been possible without the help of with the help of our cardiology department. Dr. Makkar sir, Dr. Sanjeev Sharma sir, all of them were there to always to guide us and proceed with this meeting. Marketing, very, very important. The marketing department of our hospital, because of which this event was a successful event, especially which was led by Nitesh ji, our marketing head, Vikrant ji, and because of them, this was a very smooth conference. We had no hurdles. Be it stay, be it transport, everything was very, very smooth. Then again, a very important part in the meeting is the audiovisual. I think in the last 2 days, we did not have even a single glitch of problem with the audiovisual. And that was all because the strong team which is sitting there, which is led by Navneet ji, who is heading the Vision Plus, who is our partner in arranging the conferences. So very, very thanks to Navneet ji and his team. And last but not the least, we had our sponsors from Sun Pharma Solaris division, which is led by Mr. Mitral ji. And I would like to thank them and their team. Again, they were very much dedicated. It's very difficult to, invite. And this was the event which first time we did. They were the only sole sponsors. We didn't took help of any other company, and only the Sun Pharma Solaris division sponsored everything. But more importantly, they were the only persons who invited all of you. So to bring so much gathering, all the physicians from across the states, it's a very, very difficult task. And I was wondering how they will be able to do that. But they have done a wonderful job. And again, it was very, very smooth. And Lastly, the Clark Summit staff, they were also very nice. We had no problem in the foods and everything. So I would like to thank you all. And we have a lunch waiting for us. We can join that lunch. If sir would like to add something, sir, please. Makkar sir would like to add something. So it was all because of Makkar sir that we are able to do all these meetings.
Just want to repeat what you said. Special thanks to our senior physician faculty. And this was a different kind of thing we did. Either you get to know only gastroenterology, diabetology or cardiology. So there are a lot of repetitions and overlap in the talks. So that's why we planned a multi-specialty and we tried to choose those topics who are of their clinical benefit. So we would, we'll request Sun Pharma people to take a feedback form, go back to them, please fill that, and we can make it an annual event. Depending on that feedback, we'll do the changes because it is their program. So once again, thanks everyone.
Thank you, sir. So we can join for lunch. Lunch is waiting outside, sir.